Okay, so I'm Kara. People on come to eval time don't usually have a hard time remembering me. So what happens is I have a very unorthodox method of teaching. I like to talk a lot. I like this to be interactive. I put some fun pictures and scans and whatnot into the presentation. I don't like to, you know, just look at you guys and you're all just staring at me, and you are post-lunch, I understand, right? Yeah, so that's going to be rough. So don't do it. Don't give me the nod. Don't give me the slouch down. None of that business, okay? So I like it. Be persnickety, be rough and tumble, be loud. I enjoy that. Be participative. We'll get out faster. I was told that we're here today till 1800 sharp, and we're going to be here till 1800, right? No. Oh, my bad. Oh, is that how it is? Okay. So usually everybody gets all like kind of mad and stuff like that. So yeah, we get out earlier the more you participate, okay? So you know it, okie dokie, Bert. I also have to say I enjoy the level of disbursement throughout the classroom. Do you smell or what? What is it? Why are you all the way? Ah, that's what it is. I like it. Very nice, very nice. And we've got some girl representation, chicas I like, and the dudes as well, okay? I will caution you this, if you have any questions at all, very occasionally I have people say things like, oh, are you being serious? I'm totally fine with that, okay? So if you're not sure if I'm actually serious about something, usually I'm pretty clear, but I love to be interrupted, okay? I interrupt myself from time to time, okay? But everybody is going to be learning about neuro, and everybody loves neuro, right? Really? Oh, that's it, yeah. Your face was dead on. That's what it is. Neuro is definitely an acquired taste. Most people hate it. However, it can be really, really interesting, and just know that you can absolutely affect someone's ability to go back to work and mow the lawn versus going to the group home and having your drool wiped off your chin, those kind of sort of things, okay? So, enough of that baloney. All right, our introduction slides, it's an introduction, okay? Most neurologic patients requiring transport are gonna have some sort of traumatic brain injury, but not all. There's some stuff in here about stroke and hemorrhage, aneurysms, things like that, okay? Really don't wanna ignore you, so I'm gonna try to swivel from time to time, okay? I'm not dancing. All right, so we've got some A&P. I know that it's tough. There was a lot of neuroanatomy in here, and sometimes it can wind up you get completely overwhelmed and turned off and intimidated, so don't. I don't want to say the words dumb it down, but bring it down a little bit so that it kind of makes sense, okay? Ask if you have any questions at all. So A&P, nervous system, central nervous system, and peripheral nervous system. Everybody knows that. These are the basics, right? Everybody's had A&P already, and you kind of know a little bit about it. When we're talking about peripheral nervous system, you have afferent and efferent pathways. So is everybody really comfortable with talking about peripheral nervous system and the afferent pathways and what that can have to do? It's very dry, it's very boring, it's kind of hard to remember what they do, and I understand you're going to be tested on this material. I am a person, I've learned over 17 years in the, as a nurse, adding up a little bit, 5 years on top of that. That'll tell you how old I am. This is really embarrassing. But I've learned little mnemonics that help me out. If you like them, keep them. If you don't use them, okay? Afferent is your ascending pathways. So you get the A to the A, right? Your afferent pathways are going to be ascending pathways. These are the tracks that are going to bring impulse towards the CNS. Does that make sense? So 6 years from now, you're not going to remember this at all, right? Try to remember. It's not that bad. Efferent is obviously going to be the other way. It's a two-way street, but only a two-way street. There's no roundabouts in there, hopefully. Actually, there's a couple of exceptions we'll talk about. But efferent are your descending pathways, okay? So talking a little bit more, we've got our somatic nervous system, autonomic. Your somatic is going to be your voluntary, if you kind of sort of break it down almost like that, okay? Versus autonomic, automatic, involuntary. See, they're not so bad, okay? These are very generic. They're trying to ease you into, so we won't talk excessively. You don't need to memorize all of these things. The key is not to memorize the entire periodic table of the elements, right? It's to know where to find your resources, okay? So here's a nice picture. I believe you do have this in your book. Your nervous system is essentially your brain and spinal cord, knowing that that comprises all kinds of cranial nerves and then spinal nerves, okay? 12 cranial, 33 spinal. So just kind of keep these generic principles in mind. All right, so you've got your skull, your brain box. I like that. They actually put that there. I did not add that brain box. It's a very lovely, wonderful, term that just kind of helps us remember. So you've got your neurocranium, brain box, and then your visceral cranium. Visceral, we think of what? Viscera makes us think. Viscera sometimes has to do with like smooth muscles and organs and stuff like that. What's kind of, it's not the same thing up here. So your visceral cranium is really talking about your facial bones, okay? Neurocranium makes sense. If it's a brain box, it encloses the brain, okay? We've got lots of different pictures there. And you've got your foramina. Nice picture here. Again, we're not going to dwell excessively on the pictures. You have these in your book. But this is kind of nice to maybe go back to when you're confused or you need a nice colorful picture or you can't go to sleep at night. Okay, anyways. The meninges. Everybody enjoys the meninges? Maybe, maybe not? Okay. Your meningeal anatomy and physiology. So your meninges, everybody always remembers what the dura is, right? What do we think of when we think of the dura? Or what do I want you, that's exactly it. She made like a motion like this. It's a covering over the brain. So one thing, the way that I like to kind of describe this is you have your brain. We'll pretend your brain is my fist. And then you have this balloon around your brain, which is technically all three layers, but essentially the dura, okay? Where would you say find cerebrospinal fluid, or CSF? Outside the balloon or inside the balloon? Inside the balloon, okay? So that's very, very, very easy, right? Brain, balloon, CSF's inside the balloon. It's really not that hard, honestly. Meninges, you have your dura mater, your arachnoid, and then your pia mater. We'll talk very briefly about what each of them are, okay? Your dura. So outermost layer. So we'll kind of go outward and work inward, okay? You've got the outside, what you can touch on the balloon and, you know, kind of feel, all right? So it's two layers. If this kind of makes sense, one goes out, one goes in. It's all the dura, okay? Dura mater, meningeal layer. Got your arachnoid, which is a little bit inside of that. Why do you think we call a certain type of bleed, when we have a brain bleed, there's lots of different kinds, we'll talk about all of them, but you call it a subarachnoid hemorrhage. Where do you think, medicine is so cool. If you take the words apart, you can totally get it, right? So you started to do something again. Under, sub is under, so beneath, subarachnoid hemorrhage. So beneath the, oh gosh, really? You just determined where, remember this can happen all over the brain, because it kind of encloses all over, but you just determined where that bleed is, okay? That'll come in handy when we talk about subdurals as well, and epidurals, and other sorts of things. All right, so then we'll go to the pia, which is like, it's the smallest word, it's the smallest layer, it's the closest layer. I use all kind of really funky things, but your dura is your outside, that's the one that everybody kind of talks about. The other two just kind of right underneath there, okay? The pia has a lot of blood vessels that supply blood to the brain tissue, to the parenchyma, okay? So we're going to talk about our ventricular system and our CSF, okay? I know this is all going on camera, be quiet. So our CSF. So in your brain, did you know you have ventricles, just like in this big thing here? How many do we have? Oh, he's very good. He's all alone with arms crossed and laid back and relaxed, and he's doing great. And you're right, you smarty pants, it's perfect. You've got 4. How did you know that? Oh, I was gonna say, because is it up on the screen? It says 3rd and 4th ventricle. No? No funnies? Okay, fine. Very well then. You have your ventricles, 1 and 2 are very large, and they kind of look like that, and they're almost, certain parts of it is called the horn. So those kind of go up and over, and they're lateral. Those are your lateral ventricles. Your 3rd and 4th are most central. And then after 3rd and 4th, there's actually a couple of foramens or holes that they go down, and actually the CSF goes all the way around your spinal cord, your spinal column, and kind of continuously circulates. How do we get CSF? Do I go to Walmart and grab some because it's on special? Oh, you're so smart. I just absolutely love this. You actually create it continually around the clock. We have drugs that can actually reduce and slightly enhance production. About how much do we make? Anybody have any idea? It'll be on a later slide. We'll let it be for a little bit, okay? We'll come to it. So you have the one, each hemisphere has a lateral ventricle, that's 1 and 2. We talked about that a little bit. The ventricles, this is when we put in a ventriculostomy or EVD, this is where that's going to go. Essentially, that's a straw that then sucks fluid out. If you heard somebody has a VP shunt, like a ventral pleural or a ventral peritoneal shunt, that's what that is. We put the one end of the straw in there and either bring it to the outside if they're really sick and in transport like you guys, or in the ICU. And then if they are going to need this long term, or young ones used to have hydrocephalus used to be a really bad sentence to have, and they would kind of go off to different areas. I'm on camera, so we're not going to kind of go with some of the stories I was going to tell, but having the ability to shunt that now actually will kind of drain that fluid. It's all sterile, either into the lung, the pleura, or into the peritoneal space where it will be reabsorbed, okay? And this is if the body cannot reabsorb it on its own. We won't talk excessively about hydrocephalus right now. But that lateral ventricle, either side, is where we're going to put the straw, the shunt, if we need to monitor ICP and or drain CSF, okay? All right, so very, very briefly, we talk about the foramen of Monroe. You've got, that's one of those holes that I kind of was telling you about. Things kind of go downward to kind of, keep things flowing. If you happen to have blood in your ventricles, do you think that would really help the absorption and flow of CSF? No, definitely not, really not, right? That can plug things up, because blood does what? Clot, and a clot is very like a clog in your toilet or in your bathtub drain or something like that, right? So then you can have hydrocephalus that can either be very, very easily corrected with a shunt. The blood reabsorbs after, say, a brain, a bleed, a stroke, or a traumatic subarachnoid, or we'll talk about different sort of things as they come up. I put some interesting slides in here with different bleeds, but as they come up, you might need the shunt just to kind of drain it, and then the blood reabsorbs. We sometimes try to manage overproduction of CSF or under absorption of CSF. Initially, you're always going to try to manage things medically. What does that mean? We used to call it conservative management. That gives the wrong impression, so that's why we don't call it that anymore. What do we try to do? When we treat it medically, we give drugs, okay? So we try to treat it non-invasively, okay? Kind of exactly what you were saying, all right? So we would try to give them drugs. Diamox is a big one, all right? It's a very old drug, but it works really kind of well, all right? If needed, then we can go into more invasive methods. You would do a temporary shunt, and then you might have a permanent shunt. I don't want to say across the board because it can vary from person to person and depending on the degree of spina bifida. There are some that have, part of the actual spinal cord and spinal roots exposed outside the body. That's definitely very, very, very serious. So, okay, this is more A and P. Okay, so your cerebrum is the majority of your brain. You have your cerebrum, you have your cerebellum, you have your brainstem, okay? It's really not as hard as sometimes we make it out to be. So it's the largest part of your brain. So you have 2 hemispheres. We kind of know about that, separated by the fissure. Anybody ever heard of the corpus callosum? So these words are kind of, oh, it's very intimidating. These are very big words. What does that actually mean? It's just, almost a connecting structure, okay? It's where the 2 halves of your brain kind of, get connected. We'll talk about the brainstem and the cerebellum and what each of those, each thing does as we kind of go through. Cerebral cortex, so this is really thick. It's the outside. You've got your dendrites, your neurons, your gray matter. So a lot of British, we had a absolutely wonderful, and I'll quote him a couple of times in here, a wonderful British neurosurgeon who went through his entire residency over at Fredert, and then they couldn't take him on his staff. They didn't have a position, so he left. But he taught me all kinds of interesting things, which I'll kind of quote him a couple of times throughout here. But your gray matter is you know, your second grade, your the majority of your brain tissue, okay? Boy, my goodness gracious, I'm fumbling here. It's just absolutely terrible. Underneath your cortex, you've got your white matter. There are all kinds of jokes about gray matter and white matter. Communicating impulses from the cortex to the other areas of the brain. Essentially, you've got a lot more gray matter than white matter, but the white matter is a little bit more important, sometimes is one way certain people think about it, okay? So these are areas of the brain. So which side of the screen would your eyeballs be on? Good, very good. So your occipital, that's your back end, incidentally providing sight, your eyeballs. Kind of connecting there, it's kind of funny. So your frontal lobe, the next few slides are going to go through what each one of these does, and I believe you have this in your book as well. So your frontal lobe. Anybody ever taken care of a patient with frontal lobe contusions or frontal lobe bleeds? Anybody ever had to, because it's not so bad immediately, okay, as far as what you're going to see clinically, but after these few hours to days after these, someone has damage to the frontal lobe, they get extraordinarily disinhibited, okay? Extremely disinhibited. Often you see hypersexuality, enormously so, and they have no control. So if you think about it, you've got a 20-year-old, male or female, who has been in a multi-vehicle crash, wasn't belted, whaps there, you got the spidered windshield, so they've whapped their head there. Your frontal bone is actually extremely thick and, you know, it's very hard to actually break. You never get a skull fracture there practically. But you've got talk about the coup and contra coup injuries. But you wind up with bifrontal contusions or frontal subdural hematoma, something like that, right? These are your patients who are, once that has a little time to kind of, because you know, you've got edema that happens after an injury, any of these kind of things. What happens is that they get very disinhibited, they get angry, no impulse control, looking at what's in there. You've got concentration, ability to think abstractly, memory, your autonomic nervous system. Really, essentially, why are 18-year-olds excused, especially 18-year-old males, excused from some of their bad behaviors, and we say boys will be boys? What is the last area of the brain to develop? Fully develop is that frontal lobe, right? So it takes time. So up until like 22, 23 years old, right? So boys will be boys. Never heard that? A lot of boys in here smiling. Okay. All right, your parietal lobe is just past, not the temporal lobe, but your parietal lobe. And you've got different sensory functions. So this has, if you have a left parietal stroke, okay, everybody thinks left side of the brain, what's the number one function that's going to be impacted? If I had a left hemisphere stroke, what am I really worried about? Or speech, right? So we're talking about speech, but it depends where on the left side, okay? So we're not talking temporal, we're talking parietal, but you might have the ability, anybody ever, of course no one would ever do this, you're driving down the freeway, or well, let's make it a little lower speed, you're driving down the street in your neighborhood and you really need to get something in your bag or purse if you're a lady, and you go in there and you're looking for the wallet or the watch or the lipstick case or whatever it is that you guys get, you know, that ability to tell without looking. You can tell a quarter from a nickel or a quarter from a dime. So, you know, you've got parietal lobe injuries, it's a lot of sensation. You may lose that ability to determine, you know, you're not losing nerve endings and unable to feel, you're unable to process that information, okay? So very, very benign. And I didn't change the slide. There was just one line item on it. I'm not sure why it's such a lonely slide. But yeah, that's where a lot of times where you can have blindness as a result if you have an occipital stroke. So I'm talking a lot about stroke. We'll get it to being more traumatic injuries and talking about transport and trauma when we get through in here after this A&P stuff. So temporal lobe. So this is actually on the side. So this is where we're really, really, really talking about speech, okay? So there's multiple different, and there's a couple slides on here regarding aphasia and speech, knowing that speech and language are not, absolutely not the same thing, not even close to being the same thing, okay? And a lot of us tend to group them together. You can have problems with one and or both. So sound impulsive speech. Your limbic lobe. So what is the major thing that this area of the brain is known for? Limbic system, your limbic lobe. Maybe a little bit emotions and pleasure, right? So pleasure center. So certain drugs we give are going to stimulate this area of the brain. So ever heard, I love words. There's some neat words out there. Medical terminology, we have way too many words, but anhedonia, you heard of that one? So inability to feel pleasure, that's like a major bummer, right? So we do things like go out and take drugs like ecstasy and, well, not me, you know, but we take all kinds of drugs to kind of give ourselves those emotions and stimulate certain part of our brains and stimulate the release of certain chemicals, endorphins, yada, yada. So, but a lot of moods and emotion and pleasure, okay? So I know I said the frontal lobe with the disinhibition and impulse control. A little bit here, just remembering pretty much everything with limbic system. Limbic lobe has to do with how you doing, okay? Versus, you know, like the temporal lobes are for speech and stuff like that. So your diencephalon, again, these are really annoying kind of words. They're very big words, there's a lot of stuff there, but it's just an area in the brain. Really, what's the number? There's 4 different words on there, 4 different structures on there. What's the one of those 4 structures in the diencephalon that we hear about and care about the most? Hypothalamus. So what do you think of when you hear hypothalamus? What does it do? We automatically go right to temperature control, okay? So it's hypothalamus. We want to affect the hypothalamus when we're doing induced hypothermia and all these other kind of fun therapies and whatnot. We will talk mostly a lot about the hypothalamus. It does a lot more than just temperature control, what you're thinking, okay? Your thalamus is kind of there. It's more like a gate, okay? Relay station. Kind of passes things along, not so much I don't want to say is important, but it doesn't do as many things or is not responsible for as many things, okay? Your hypothalamus, you do lots and lots of different things in here, okay? So it's underneath. Hypo means below. It's the easiest thing ever. So below the thalamus is your hypothalamus, but then there was subthalamus. There was all kinds of other things, right? But it forms the floor. It's below, just kind of thinking about below. Has a little bit to do with the pituitary gland and secretion of different hormones and whatnot in the pituitary gland. Mostly internal body environment. Do you know that when you're feeling full, that feeling of satiation, okay? That feeling of, oh, I feel really good now, I had 8 pieces of pizza, I'm good to go, okay? That usually comes from stimulation or release of hormones within the hypothalamus, okay? It's not just about temperature. So we should come up with a good drug, at least in my case, a really good drug to stimulate my hypothalamus so then I would stop eating and then I wouldn't be so big. It's like, dang it, you know? So this is another slide. I believe you have this table in your book, but this is really all functioning on the hypothalamus, okay? So the big one, temperature regulation, everybody thinks about that, okay? But your level of feeling satiated, okay? Your regulation of water intake. Who's ever gone out on a Friday evening? Don't lie, I know we're on camera, dang it. Dag nabbit, right? But who's ever gone out on a nice Friday evening and just passed a giant test? Everybody's in the class right now, it's very annoying. You passed a huge test, you're gonna go relax, and you're gonna go have a couple of beverages, huh? Waters, absolutely waters. So maybe you have something a little stronger than water. Maybe water with some whiskey in it or something else, right? Do you ever know? It's good. Yeah. Do you ever notice when you're out there drinking and whatnot, you, if you were the type to do that, never myself, absolutely not. But if you were the type to do that, how your urine output increases? Gosh, I just went and I got to go pee again. I can make it through a 12-hour shift at work, just fine and dandy. But my goodness, I'm going out to have a good time with my girlfriends or my boyfriend, guy friends. You guys don't call each other boyfriends. And you're having a run into the bathroom every hour. That's because your osmotic pressure, okay, your alcohol actually induces, okay, what is released from that makes you pee a lot? There's a hormone, antidiuretic hormone, okay? Kind of has to do, coming from hypothalamus, actually has some control over the release of this. If we take the word apart, antidiuretic hormone. Alcohol specifically will inhibit or increase. Thinking about you pee more, so does alcohol inhibit or release the production of antidiuretic hormone? Well, a lot of the brain, the conversation works itself, it's very backwards, okay, the way that we talk. I'll let it be a little bit. It's going to come up again in a couple of slides, okay, and then we'll talk about it again a little bit more there, okay? Why do you get a headache, a hangover the next morning? That's it, okay? It's not you need your vitamin B12, all this, that, the other kind of stuff. You are massively dehydrated, okay, because you peed out way too much, okay? So we'll let it be for a little bit. We'll come back to it. But again, that control those pituitary gland and all those other things that kind of come out of there. And again, you have that table in your book, I believe. I'm not sure the page. It wasn't included on here, so. 373. Fantastic. Good stuff. All right, so your basal ganglia. This is a very fun-sounding kind of word. Not very fun when you have problems with it, though. So you've got, these are deep within. This is not the, people see basal and they're thinking like brain stem. But no, it's not. Basal, you know, kind of like the bottom, but it's not within the brain stem itself. But your fine motor function. So hands and lower extremities, your fine motor. So your ability to pick up a pen and write with it. So basal ganglia, fine motor function. Bad place to have a bleed. Bad place to have hypoxia as well. Every place is really. So, all right. So now we're going to get to the brainstem. So the brainstem is extremely important, right? Everybody knows. A lot of life-saving, you know, life-producing functions take place in the brainstem, okay? So you got your respiratory center, a lot of other things kind of butt up against there, but in the brainstem, so this is cerebrum, cerebellum, brainstem underneath. Coming down, you've got midbrain, pons, and medulla, okay? So I was going to do all sorts of references to popular culture, but we're going to hold on that for right now. The pons, you got your locked-in syndrome. Is anybody... This is horrible. Anybody ever heard of a locked-in syndrome or cared for a patient like this? No? Okay, so if you stroke your pons, and it's very hard to get traumatic injury there, okay? But very easy to cause damage resulting from edema, you know, things kind of pressing down, and you can have a stroke in your pons. A pontine hemorrhage is terrible and very often will result in a locked-in syndrome. So it's low, so in the brain, so you have all your cognitive abilities there, and a lot of times what happens is you have an absolute inability to move, okay? Completely locked in. It's horrible. Often, everything. Often, respiratory is gone, because remember, brain stem and what's controlled all in there, but often they have control over their eyes, and this is normally how we communicate with them. So they can blink and move their eyes depending on the location within the pons and how severe the secondary, we'll talk about primary and secondary injury is. Some, a little bit can, you know, a little bit of function can come back, but it's usually from the neck up, okay? So it's, you think, oh, it's like being a quadriplegic. No, it's much, much, much worse, okay? So they have the ability to move their eyes up and down. Rarely they will have the ability to move eyes side to side, but that's how we communicate. Are you in pain? Look up. You know, are you, do you want to see your son? Look down. You know, these kind of things. Very, 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 very bad thing. So if you ever hear or, you know, read in the history of your patients about a patient having a pontine, and often it is from a stroke, okay, having a pontine hemorrhage or damage to the pons, look for absence, almost complete cessation of muscular movement, okay, and ability to control. It's not from the spinal cord, right? Why is it having an effect like that? Because it's within the brainstem, so it kind of affects everything, okay? The brain does rule all. So I'm a former CDICU nurse as well, and we could transplant one of these, and we can't transplant one of these, right? No, we just haven't figured it out yet. That's not a popular view, but I was a neuro-ICU nurse and a CDICU nurse, so I can kind of say that and make fun. All right, so you got your midbrain, We'll talk about the most important feature within the midbrain is going to be your reticular activating system. Does anybody remember that from anatomy and physiology way back? Your RAS. What's it important for? Everything in the brain is important, I know that, okay? But your RAS, does that even sound vaguely familiar? So it's your level of alertness, okay? Very, very, very closely associated. Damage to the RAS is a result, a lot of times, of something called a DAI, or diffuse axonal injury. Has anybody heard of that? I've got some slides in there later on. This is another very sad, everything in neuro is sad. There's a lot of sad. I try to put some happy faces in there as well, okay? But a lot of kind of sad cases. When we talk about, so kind of, you know, your whole brain, brain stem, spinal cord wind up being back down there. But seeing, let's just briefly go back to the PONS. So looking at where it is, and if you, this entire area, there's not a lot of room to allow for swelling. So swelling can be the huge, huge, huge enemy, okay? So let's say you've got somebody that's really, really, really sick, and they've got damage to the PONS or, you know, cerebellar injury. You can have swelling that can kind of push things in and whatnot. But we might have an ICP monitor in. What do you think their ICP would be? Normal. It can be completely normal. You can actually herniate and become brain dead with a normal ICP depending on where the injury is. So one of our biggest problems as healthcare providers, no matter where we work, pre-hospital, in-hospital, doctor to EMT, we all get very reassured by numbers, right? What's your favorite blood pressure? 120 over 80, 120 over 70, 120 over 60. We like what American Heart likes. What's your favorite map? 60, 65, if better, okay. Systolic, American Heart likes 90. All these kind of numbers we get result. What's our favorite ICP? Oh, good, we're going to talk about this. So it should be less than 15, okay. Really want to see it less than 15-ish, you know, right around 15. So we get happy with numbers, but remember that it's a full clinical picture, okay. It's not just, don't get reassured by numbers. So more information about the PONS. We've got going, you know, back and forth. So damage to the PONS, even though you don't have any damage to the spinal cord itself, will result in, because it passes things along to those spinal cords. So this is why you have that full, absolute inability of, you know, being locked in. It's just the absolute worst ever. Full, complete awareness, and really, I've seen it several times, and it's absolutely horrible, whether it's a, I mean, it's usually older patients. I haven't seen it in someone younger, but whether it's a 45-year-old or an 85-year-old, only the ability to move your eyes up and down is just completely terrible. So you've got your apneustic center, apnea right there. What does that word kind of make you think of? I know it's all up on the screen. It's in your book. No breathing, apneustic center. It's really kind of nice. Okay, everybody's getting that? So the little thing here is very frequently you have a pontine stroke. Okay, you've got your pontine CVA, you will be unable to wean the vent, okay? This is no respiratory issue. It's all because of the drive, anything within the brainstem specifically. You're just not going to trigger. Your diaphragm will be working fine, okay? And we won't even talk about diaphragmatic stimulators, but just kind of you're not able to produce good sustained respirations, okay? Different than spinal cord injury, okay? We always want to kind of, you know, divorce and or lump together the brain and the spinal cord. They are kind of together, but we have to be careful that we don't, mechanism is really important, the patho as to what's going on behind. So, okay, either way. All right, so we'll talk very briefly about the medulla. So I was going to make a reference here to what comes into everybody's mind when you hear medulla oblongata. What is it? Thank you, okay, I'm not the only one to say it. I didn't say it myself. I asked the question and they came up with it. They didn't tell me I was gonna be on camera, so. But yeah, the water boy and the guy that looks like Colonel Sanders, and he's the medulla oblongata. Yeah, it's very funny. So maybe kind of, I was gonna put a picture of Colonel Sanders in here, but I couldn't find one. Darn it. You know, KFC bucket and see if you guys got that reference, but you did it all by yourself. You're good stuff. So it kind of connects through the foramen magnum. Magnum's big, the big hole, okay? Connects with the spinal cord. It's not the hole, it's a structure that connects to the spinal cord through the big hole. Okay, it is quite important. This is a huge cue. So if you get asked to transport, you're not going to know this if they're in the field, you're picking them up and taking them in, but oftentimes we will transport patients from one facility to another, right? We always have to, keep in mind EMTALA and all those very serious regulations and, best level of care that's most appropriate for the patient at the right time, okay? If you always want to know the diagnosis of your patient, right? Excuse me, you want to get some report on what's going on, right? So if you hear, I've got a stroke, ask for the location of the stroke. You're going to hopefully know a little bit more about this. You're going to forget, kind of a lot of it. But if you ever hear the words, some ventricular blood, immediately ask. Or if you see that straw coming out of their head and the fluid is bloody, ask. Where is the blood? If the blood is in the fourth ventricle is quite close to the medulla oblongata. Yes, kind of emptying there, right? Your vomit center is there, okay? Your patients that have blood in the fourth ventricle, so this is deep blood, okay? So it won't always be bloody fluid because this is deeper down blood. Blood is heavy and it sinks to the bottom. But blood in the fourth ventricle equals lots and lots of high pressure, high enthusiasm barfing. And just because they have an ET tube in does not mean that they won't barf, right? And will all the Zofran in the world help this? No, because it's a physical stimulation. Okay, so then hopefully you take one little tip away out of here, okay? Are you with me a little bit? A little bit. Ask for report. You deserve a report. But it does lots of other things as well, okay? So you're coughing and all that kind of stuff. Okay, so we had cerebrum, midbrain, cerebellum. So it's a different color, different kind of texture, looks different, but it's in the back, not the occipital lobe, but underneath. And really hugely, majorly has to do with coordination and movement, okay? So you have somebody with cerebellar damage, okay? They will have herky-jerky movements and not be able to, have nice, smooth, coordinated muscle function, okay? So especially with gait. So this is not like your patients with essential tremors or anything like that. Really definitely looking kind of at gait, okay? So not like, the gate that you open and close, but how good am I walking down the hallway or whatnot. Okay, great. So that's our, what's that called? Oh, you're so great. And this is called the, oh yeah, that's your cerebellum. It's colorfully, enabled on the slide here. It's not usually blue and green and red. So anywho. All right, so now we're going to talk really heavy for just a moment about reticular activating system, or your RAS. So hopefully I'll just call it RAS from now on. Okay, so you have a system, really this has to do a lot with your level of alertness, does a couple of other things as well. But when you have, so I put this little footnote here to just kind of remember to watch for DAI and rapid deceleration injuries. Give me an example of a rapid deceleration injury. Very good, rapid deceleration, right? Car decelerates and then the person decelerates and then the head decelerates and then finally what decelerates? The brain within the head because it's got that nice cushy, kind of back and forth kind of stuff there. Okay, so another frequent time that you would see this, so that's like, it's not the fall that kills you, it's the sudden stop, that kind of sort of thing. But you've got a rapid deceleration, but maybe not as abrupt as a car versus tree, which is a great example. A fall, another really abrupt stop. It's season out. You guys saw me, some of you saw me walk in with some gear. I didn't bring shoulder pads today, guy. Come on now. But a helmet indicating I may ride a, So motorcyclists, they are going really fast, or hopefully the speed limit, but a lot of times, as young males, they like to impress us girls. And statistically speaking, Mark is smirking over there, statistically speaking, who's injured most frequently in traumatic accidents? Males under age 35, yeah. Has it gone up or down over the years? No, it's kind of like the same. Well, it ticks up and down. We find very interesting ways to injure ourselves. We're the weirdest species ever. Can't imagine sometimes how we are able to survive. But you are driving along, and then your bike, whatever, and then you go and you tumble. Maybe you suddenly stop, but rapid deceleration. Maybe not as fast as that instantaneous deceleration when you hit a tree or a building or another car, but that still really fast deceleration. Those guys, and girls, I am one, very, very, very prone to DAI, okay? So DAI, and I have a nice, animation to show you after. I can't remember, it's in here, a couple slides. but it's a shearing injury, okay? And it is very, very, very dangerous. You made a really nice face there. Shearing, what do you think of? What do you think is happening? Exactly, and it doesn't tear things neatly. So you've got, everybody know what a neuron kind of looks like? Axon dendrites, okay, so you've got your axons here. So if this is brain cell number 1, and this is brain cell number 2, what happens to get the impulse from my brain to my left foot, we'll say? Does it walk across? It jumps across, right? So it jumps across, okay? And if you do this to your brain cells, maybe the neuron itself is possibly partially still fine, okay? But it strips off those fingers, those projectiles, and now that impulse has a very, very hard time. Let me just spit on the table a little bit. Good thing nobody's in the front row. But it jumps across, right? But if now this middle one, there's not a receiving finger, okay? Instead of jumping over a little puddle, you're now jumping over like the Potomac River, right? So it gets harder and harder and harder. Your DAI, your diffuse axonal injury, diffuse means what? All over, exactly. Axonal is damage to the axon. Smart, an injury is an injury, right? So you've got a lot of damage to the axons, and it's almost never localized in one area. It's very spread throughout. I know the name of it is diffuse. But depending on how many are injured, you can have mild, moderate, and severe. These patients, because of the damage to the RAS, will not wake up. This is a patient that subdural has resolved, that subarachnoid has resolved, their bones have knit, their asphyxes are coming off, and you still can't get them weaned from the ventilator, okay? So clinically what you might see is a lot of yawning, you'll see a lot of chewing. These patients will live a very long life in the group home, okay? Very sad. There is absolutely no way to fix that, okay? I know there's a slide a little bit further down about DAI as well, so I won't go heavy into it right now. But does that kind of make sense, that rapid deceleration injuries, really, 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 that DAI comes from rapid deceleration injuries, very closely associated with damage to the RAS. Sleep wakefulness cycles make sense. You just can't get them all the way awake. A lot of yawning, can't wean them from the vent because they're not having enough of a level of consciousness. So your brain, is it this? I'm trying to say that your brain is, what is this? It's a piggy bank. Is your brain a piggy bank? Well, you put all kinds of information in there, is it? Very good. So your brain is not that. Your brain is that. Your brain is a hog, okay? It is a pig. What do I mean by that? Your brain consumes 20%, truly 20% of your resting cardiac output every minute. But it's only 2% of your total body weight, okay? It's very, very important, all right? You will sacrifice your fingers and toes, without meaning to, your intestines, then your kidneys, then your liver, then your heart and lungs to save this, right? So your brain really, really, really is important, but it's definitely a hog. 20% of your resting cardiac output every minute, okay? And it's only 2% of your total body weight. It is supplied by your vertebral arteries and your carotid arteries. So some funny stuff. You guys are all way too young. Thank you. I know it was up in the title there. Most of you are way too young. There's a couple of you with my, that was funny. Does anybody get that? Sorry, okay. What you talking about, Willis? It was a show called Different Strokes. It was great. It was wonderful back in the 80s. It was fun. All right, moving along. Let's talk about the circle of Willis, okay? All right, so your circle of Willis is really important, okay? I also want to get that t-shirt real bad, but I can't find it anywhere. I just could find pictures of it, but I would buy one if anybody can ever find that. I'll buy it off you. It's a very important system of arteries where things kind of branch off of, and really this is where like all of your aneurysms come from, okay? Damage here, we'll talk about them specifically as they kind of come through. So you've got your basilar artery. I know this is a little bit fuzzy, and I don't know how well it's going to come up on the camera, but I tried to make it bigger, and then it got kind of fuzzy, but still big enough so you could see it. But the little balls here with the numbers are telling where your most common aneurysms are present, okay? So you've got your carotids, you know, it kind of branches here. You've got your basilar artery, you've got your cerebral arteries, okay, so give an example here. So, you know, when we were talking about the lobes of the brain, your temporal artery, so you have an artery that runs there called the middle meningeal artery. So 93% of all epidural hematomas come from a tear in your middle meningeal artery, okay? That's a really interesting statistic. What does that mean to you? Are you going to see an epidural hematoma in somebody that has spidered the windshield, or when someone was hit upside the head with a baseball bat? Mechanism, right? Go patho, kind of like what to expect, this, that, and the other. But your aneurysms, okay, about 40% of them come from tears in your anterior communicating. Very, very common place for these aneurysms to occur. Aneurysms are bad things, not so bad until they blow, and then they're really bad. But just a nice, interesting slide. Actually, you have that now. So I was going to send that, but I don't need to now. So you got your verts, your vertebral arteries. They come off of the subclavians, entering up through the big hole. And then at the pons, you've got your two verts that join to form the basilar artery, which then goes into that circle of Willis. Everybody sees why it's the circle of Willis, right? What you're talking about, the big circle, everything important comes out of it. It's great. It's like the Olympics with the circle rings and everything. Okay. So basilar artery does divide then, and we just saw the picture of what all that is. Sometimes a visual is a lot better than just words up on a screen, okay? Moving along. All right, so then you got your internal carotids, okay? So they kind of come off. This is essentially that slide kind of describing piece by piece. This is what the circle of Willis is. It's hard A and P. It is, you have to memorize it. There's not really much I can say about that, okay? It's just, it is what it is. Circle of Willis is good stuff. It's really important. All right. Incidentally, because I like stories, I think they kind of help sometimes, a dog, it is virtually impossible, as soon as I say never, something's going to happen, but it truly is virtually impossible for a dog to have a stroke. Any idea why? Their circle of Willis is very huge, okay? The shape of their skull, the shape of their brain. So if you see a dog leaning drunkenly, he probably had beer instead of, you know, having a stroke and having left-sided weakness or something. Often they can get spinal plexus injuries. I know this is kind of weird, okay? But I love dogs and like to help dogs out and stuff. And it came through a neurologist as well, just so you know. I didn't go investigating any dog brains. But having a dog, it's virtually impossible for them to have a stroke of any sort, clot or bleed. They aren't tending, you know, to bleed, but their circle of Willis is really gigantic. So lots of their vessels are very large. Lots of blood flow can get around any plaques. So feel free to give your dog all the McDonald's he wants, okay? I have 210 pounds of labs at home. I love them very, very much. But yeah, and they're Labradors. No joke. Sorry, I can't help it, okay? But yeah, Labradors, no. Rotties actually have the largest heads, bigger than a pit bull. Mm-hmm. Rottweilers, that would be for AKC type people. Ooh, it's time for a break yet? Okay, not yet. All right, so venous drainage. So your veins, arteries and veins, everybody knows what artery does, right? Artery takes blood under pressure, gives it out, makes the masses happy, the masses being our fingernails and teeth and brain cells and all that, okay? And then veins take the blood passively back, right? To do that wonderful cycle and get oxygenized and kind of brought back out there again. So the stupid neurologist, do you ever take a patient in transport yet? If you haven't, just wait a little while when they're going from one ICU to another. So if they come in with traumatic brain injury and or a stroke or something like that, and they always want to put those stupid subclavian central lines in instead of a nice IJ. Give me a big old IJ any day over a CVL. Why do you think they prefer that? Oh, I mean over a subclavian CVL. Why do they like that? Let's take a look and see. Venous drainage. So things getting out of the brain can really affect your ICP. So you ever have a view, this is a wonderful slide, it was actually in here, I didn't put this picture in, but you've got your EJ and your IJ, okay? So I can go ahead and slip a 16 gauge into his EJ, no problem. Don't need an x-ray, none of that stuff, right? Fine, great, wonderful. You'll even have neurologists that will do that, okay? But an IJ, which is where every cardiac, every CT surgeon in the universe wants an IJ swan, not a subclavian swan, right? Catheter. Creaking silence. There, you guys are kind of freaking me out there a little bit, but okay. Why do we not want, look at the size of it, okay, versus, you know, your subclavians kind of coming in here. Still central, okay, but why do you think the neurologists and neurosurgeons don't want to plug up that IJ? Good. By what method? And not so much directly cause an increase as prevent a decrease, because it's big, it's huge. So you get a lot of, remembering both sides, okay? Most people are right dominant, okay? So the right is bigger. But look at the size of the IJ, okay? It's responsible for draining. Where does the EJ drain from? Right. Where does the IJ drain from? Can you see it maybe a little bit? Inside. So we will talk in a little bit about this wonderful doctrine, the Monroe-Kelly doctrine. People have heard of that. It's one of my favorite doctrines, okay? It really is. Not doctor, but a doctrine, okay? A school of thought. It's good stuff. But having a big honkin' catheter up there, either a, just a central line that, or a swan catheter or something, anything that's, introduced or anything that's really, really big, can plug a lot of drainage, slowing drainage from the brain, thereby slowing the reduction in fluid out of the brain, thereby reducing the, or, kind of increasing or maybe not allowing for the reduction of ICP. All right, blood-brain barrier. So we've got, it's very selective, it's very choosy, it's a diva. Your blood-brain barrier is a diva, okay? Think of it like a princess, a really snotty princess, okay? What does that mean? So you've got your blood-brain barrier, right? You've got this really hot club everybody wants to go to on Friday nights to have ice water, like we were talking about earlier, right? And there's a line all the way down the block, right? Who gets in? Only only very, very few people get in. I would never get in a place like that, okay? No worries. So your blood-brain barrier is that selective, obnoxious nightclub, only letting certain things in. Too many of the wrong drugs in, right? And it kind of, we have to tailor antibiotics and all sorts of other things to what will actually affect and get through the blood-brain barrier. Really impressively important aspect, only took up one slide. It's kind of like, Okay, so we're going to talk a little bit about your spine. You've got bones, so they call it vertebrae. You'll hear neurosurgeons will always refer to it as the vertebral body, almost always. But they're stabilized by ligaments, by muscles. They're, that's the, I broke my back and yet I'm still walking around, okay? The body, the vertebral body, and the spinal cord are two completely different things. Please keep that in mind, okay? So they're just, cervical, thoracic, lumbar, sacrococcyx, okay? All right, so you've got the vertebral body itself, weight-bearing, very heavy bone. Incidentally, you can tell on a CT scan what level of the spine, even if you can't see any curves present, right? You can tell what level of the spine you're at based on how large they are. Where are my largest vertebrae? Lumbar. Why is that? Yep, because that's where you carry most of your weight, okay? Don't judge me. Okay, anyways. How do you get your curves in your spine? How do you get your thoracic curve? When you're a little baby in the tummy and you're curled up in a ball, you get your thoracic curve, okay? And then when you're out learning to crawl and you hold up your head, that's how you get your cervical curve, right? And then we gradually learn to walk, and that's how we get our lumbar curve. So you've got a spinal cord injury without radiographic abnormality. What in the heck does that mean? What they're talking about is like a stunner, or he probably concussed his spinal cord. Did you know you can cause a spinal cord concussion the same as you can a brain concussion? So that's likely what that was. So I always think about like Jerry Maguire, when dude's like running down and he catches at the end of the movie and he goes from being a crabby into like this great person that everybody loves, at the end, how he was like knocked out, but then he also couldn't move or anything. And then finally he got up. You hear about this a lot in youth athletes, okay? So that stunning or concussion can happen. Skiwara's different. That's it. And not entirely, but almost exclusively related to what population? Take a guess. Young ones, really, really young patients, right? Kids. So you think about kids as being like 10 or under, and old people as being, it gets older for me every year, but old people for me are going to be over to 80 now, okay? So don't judge me. I just had a really big birthday last week, which made me sad. But why do you think a child, say an 8-year-old, would be more susceptible to having a spinal cord injury without radiographic abnormality? What does that mean, radiographic abnormality? We can't see it on, and incidentally, you can't see cord injuries ever on CT. They always need to go for a, you got it, MRI, the most annoying road trip, because MRI will actually show the cord. I don't think I didn't put any, I put a bunch of CTs in here, but I didn't put any MRI pictures. I kind of ran out of time. I wanted to do some cool stuff, but hopefully you'll think it's somewhat cool. Anyway, but getting back, why would we couldn't see it on X-ray either, okay? Because we can see the vertebral bodies on X-ray, and they will always do X-ray films as well, okay? But the one right off when they're sick, they have to get an MRI. Everybody goes to CT now, right? Sure, they'll CT you from here to here, right? Just because we don't get sued now, so we kind of CT everybody. But we'll CT you, but then they will also, if they have any cardinal signs or mechanism hinting at a spinal cord injury, they will absolutely get that MRI done as soon as possible. And then they do serial exams. And the reason for that is your spine will swell just like your arm if you get punched, and there's not a lot of room in there. Okay, and we have a picture of a vertebra coming up, so I won't talk about it right now. But anyway, back to the original question. Why would a kid be more susceptible to this than, say, an 80-year-old? What specifically is less developed in them? I can be 8 years old and be run over and not have any rib fractures but be all squished inside because my bones have not fully ossified yet, okay? Yep, so they're very flexible. So when my kid was 5 and he broke his arm, okay, what kind of break do you think it was? Green stick. They don't break, they're not fully ossified, they're not hard, they're still kind of growing and everything. So you can have, and this is really kind of more you're talking, and if you think about it in terms of stroke, TIA versus CVA, you know what I mean? So you got your stunner or your bruise or your concussion, which incidentally is a rule out sort of thing. You can't see a concussion. It's a set of symptoms, you know, that you kind of get by exclusion, you know, of everything else. But versus Skiwara, you can have somebody vertebrae look just fine and dandy, usually the kids, and then they can, you know, have not just numbness and tingling, but they can all have all the way through actual complete, you know, loss of sensation and motor. Okay, so you know, being paralyzed, terrible stuff. So I think that was all I was going to say on there. Okay, so here's some little pictures. Again, no patient identifiable information here. So this tells you just looking at it how old it is, right? But when I first started, we would walk in and have a chart, and you could flip up and see the pictures in there. They would put the crash scene pictures in there, right? We're not allowed to do that anymore because it's uncool. But hearing about a motor vehicle crash, rollover at 45 miles an hour is a little different than actually seeing that, and that guy is going home? You know what I mean? Or you get the very barely dented this, that, or the other, and that guy didn't make it. I keep saying guys, I mean girls too, you know what I mean? So just little, you know, kind of trying to spice up the presentation for you. Okay, so here we go. We've got our vertebral body. So the front, so where's my belly button? Oh, good, yeah, very good. So looking through, don't judge my belly button either, okay. So we've got our vertebral body, and then this little hole, so this is us looking down, okay. This little hole where the spinal cord is. So this is your cord, these are the nerves that kind of come off of it, and I don't want to talk about that, but kind of moving, and as far as space-wise, do you see a lot of room there? Really not a lot of room, okay? And certain areas have less room than others, okay? So there's really, really, really not a lot of room to allow for those natural compensatory mechanisms. We have autoregulation intact, okay? That means that if I come across and smack you upside the head, or you know, smack you across the face, your face is going to get swollen a little bit, right? As the injury and the body tries to, you know, kind of help things out. Normal internal mechanisms, when you have a scratch here and you get a scab inside, what's going on? Your body is increasing vasogenic edema, right? Bringing extra good little soldiers there to kind of clean up the bad stuff and the dead stuff and get it away. That stuff goes on not just on your hand and arm, but inside throughout everywhere. The only reason it's such a horrible thing in the brain and the spinal cord is that there's no room. Remember that brain box? There's not a lot of room, okay? And definitely when you come out of the brain, there's more room in the brain box than there is going all the way through, okay? So we've got to really, really, really be careful. Been over the last, you know, 10, 20, 30 years, a lot of therapies have gone in and out of vogue. Very briefly, what's the one therapy that used to be a standard smack automatic? We had to get it up and get it going as soon as humanly possible when someone had a spinal cord injury that is now huge breaks, okay? We're talking within 15 years it's gone from the gold standard to being don't you dare unless you have good reason. It's a very short amount of time. Spinal cord injury, good, steroids, okay, so your SoluMedrol drip, okay? So it used to be when I first started in the field, it was, oh, okay, we're getting this guy going there. If we had to exactly to the minute know time of suspected injury, because if he was started that steroid drip 3 hours or less from time of injury, he would only need it for 24 hours. But if it was more than 3 hours from the time of the actual injury, kind of almost sounds like a stroke nowadays, doesn't it? Then he would get the 48-hour drip. Why do you think and it does do its job, why do you think we started doing that? Why did everybody with an automatic hair trigger, knee-jerk response? If somebody had a spinal cord injury, why did we give them a SoluMedrol drip? Boom, because there's not a lot of room there, right? Did it work? Yeah, most of the time it helps a little bit. It's going to do its job. Brain injury patients often get steroids after. They get Decadron, right? And especially post-surgicals, they always get Decadron scheduled, okay? It works, it does its job. Not all the time, but you know, it works. Why do we not, and incidentally, practice has not fully kept up with the literature throughout the country in this, but why do we, whoa, don't do that? Why don't we want to do steroid drips anymore? What do steroids do? Both of you are right. What do steroids do? Anti-inflammatory, so they will reduce, you know, the swelling. What is the flip side of steroids? Non-discriminate. What do they destroy? Your immune system. It's gone. Not forever, but it's gone for the length of time that you're on it, right? What else do steroids do? Anybody on prednisone or Decadron, dexamethasone, SoluMedrol, what happens? Something goes way high. And somebody that doesn't look like me, this number would go way high. Not weight. Well, weight, incidentally, because it increases hunger. It's a lab. It's a number. It's really easy to get. It takes like 20 seconds or less. Finger stick. It will drive your glucose level through the roof. Why do we not like that in any patient, especially not in trauma patients? So steroids are good, yes, but they are bad. So a healthy 20-year-old, truly, okay, and I work at, you know, Freidert's Level 1 Trauma Center, worked in our neuro ICU for 7 years full-time, okay, still staff up there. I was up there 3 weeks ago. So looking at that, we get patients in from other hospitals and started in our own hospital when they present to us, and we still do steroid drips sometimes. You don't see a 48-hour drip. I have yet, I don't want to say that because as soon as I say that, it's something, you know, as soon as you do always or never, it's done. But you really don't see two-day drips, but you will still occasionally see a 24-hour drip. Why do you think we're willing to take the risk? Who would we start that on? 20-year-old or an 80-year-old? Why the 20-year-old? They're probably going to be able to fight off the rest of the nonsense, right? They're going to be able to suck it up and soldier on and get through, okay? And if they take a little bump to the kidneys or a little hit to the, you know, they'll be able to, you know, get it. They don't have as many comorbidities. They probably don't have advanced atherosclerosis going on and diabetes type 2 and things like that, okay? Incidentally, American Heart has done some studies showing advanced atherosclerosis in 16-year-olds, in 30-year-olds. Oh, we're like a McDonald's society. Me too, I'm sorry, but it's a bummer, right? But they're more likely to do it in a 20-year-old than a 60 or 80-year-old, okay? But still not a hair trigger thing, but you will still see it done. The literature says you really, really, really should not be doing it unless there's absolute proof, but in practice, we're lagging. We're still seeing it started, not with full regularity, but with some regularity, which is kind of a bummer. So, never be afraid to ask the question or speak up and say, do we really need that? Because sometimes, you know, they listen to us, right? Oftentimes, traumatic spinal cord injuries, which are the ones that are most likely going to get this, right? Traumatic injuries, your diving accidents, I took care of a guy who fell off the second level of moron, idiot, got drunk and went off of Miller Park shortly after it opened, and walked out of the hospital, mind you. Holy moly, okay? But traumatic injuries, often, especially with spinal cord injuries, what happens and may hasten the arrival of atelectasis, which then is, you know, leads to pneumonia. Traumatic injuries, not protecting there. And then what happens often, people don't usually go out and diet and then get in a traumatic injury. They go out and have what? Lots of ice water and beef brisket and, you know, all those other interesting things, and then they go whoops, and it goes whoops. Yeah, that's bad stuff. So a lot of times, you know, a neuro injury, head or spinal cord, you're almost guaranteed to get a pneumonia, really. They are allowed by, okay, without getting too much into it, but brain and spinal cord injuries are allowed a higher level of pneumonia before Medicare and, you know, all those other kind of things start withholding dollars, only because they have a lack of protecting airway. It's not significant, okay, but I mean, it is significant when you're talking dollars. But all right, so spinal cord, we've got origin starting up in the base of the brain and then kind of going on down. It is your central nervous system. When you start talking about nerves off of it, that's your peripheral, right? So your central nervous system. Okay, anyway, so you've got your 31 spinal nerves kind of coming off of that. Incidentally, your cord doesn't go down to your coccyx, right? But your nerves do. So you have that classic, and some of you are in my age range, which could say, so you've got that, ooh, my butt hurts, and my second and third toe are kind of like numb and tingly. What's that? Sciatic pain, 'cause my sciatic nerve coming out of my spinal cord. I don't have a spinal cord injury, right? But you got a disc that's slipping out, putting pressure on that nerve, resulting in those symptoms. Use your lifting machines. That's good stuff. Okay. So we talked about what this was a, that's a, you know, kind of looking at a view. You've got the butterfly shape, it's a very pretty shape and whatnot, but it does all kind of sort of stuff. When you talk about dorsal horns and ventral horns, back and front, so it's one of those things, throw it away if you don't want it, don't worry about it, but I find it helps me a lot because I have like file cabinets up there in my head and I can't always remember everything. So when I want to know what does what, perchance if I were asked later, you know, at some point, somebody comes up and says, well, hey, what happens and what does the dorsal horn of with your spinal cord, those dorsal horns versus the ventral horns, what does what? I think about dorsal horns, I go to a dorsal fin. Where's a dorsal fin on a shark? On the back. And if you rub my back, I'm going to feel good. Don't judge me, okay? We all do what we do, okay? But my back, okay, dorsal horn, okay, carries the sensation, all right? So it feels good if you rub my back, the dorsal. So then you've got your anterior or your ventral, okay, is going to be just like the opposite. So that would be your belly. But you've got your ventral surface, your ventral horn, which then has movement, okay? So it's kind of like sensation, movement. If that helps, if it doesn't, whatever. It's just how I classify it in my head. Use your own stuff. It's fine and dandy. Anyway, that's what that happens with those nerves. Okay, here's a nice picture of the cord itself. So I like this. This is from your book. So it goes whoops, and it kind of cuts it out so you can kind of see where it is. Incidentally, what are these things called?
Words?
They are words. I like them a lot. So they are meninges, yeah. So we all kind of think about the dural, you know, the dura or the dural tear or whatnot. So you've got your dura, your arachnoid, your pure matter, and then inside of that you've got your spinal cord. Just like up here, you've got that brain and balloon, you've got spinal cord and balloon, okay? All right, so kind of moving on, kind of looking how things are, you know, coming out of it. Here's a nice, so your cord, you've got your central canal, you've got your cord, your gray and white matter that kind of comes out. You've got this being your dura, so the outer edge of the balloon. What did you know? So we talked about what you can do to your spine. You know you can concuss your spinal cord, right? You can stun and lose, and then it wears off. Hopefully about 20 minutes is a good rule of thumb, okay? Longer than 20 minutes, it's kind of bad. Loss of consciousness is 5 minutes. If you're out, okay, but if you're out more than 5 minutes, the neurosurgeon's ears perk up. What? Those kind of sort of things. But did you know you can infarct your spinal cord? What are you thinking of right off the bat if you have a patient come in? I'm sorry, if you, which talk am I giving here? So you go to the patient in the field, you block and strap them and tape them, fine and dandy, low blood pressure, having a little trouble going in and out of consciousness. You get to the ED, you're taking them over and they start undoing the clasp, and if you haven't seen it yet, you're undoing your buckles and his legs kind of go like that. What are you thinking? He's got a spinal cord injury. That's honestly where all of us go to, bilateral external rotation of the legs. If you see the little hallmark indicator in the gents that's not there present with us ladies, what's that called? Priapism. They're not happy to see you, right? That usually indicates Okay, it's a funny joke. Is it the camera? It's not my joke, but I tell it, and usually I get more of a giggle than that, even when there's boys and girls in the class. But fine, okay. So you've got priapism and bilateral external rotation of the legs. You're kind of thinking, oh, big hallmark indicator. And really the major thing is mechanism, right? Diving injury, fall, sudden stop, those kind of sort of things. But infarction is really, kind of more rare. When is one time where maybe you would present, you're having bilateral to somebody's house, bilateral external, they're not moving their legs, they're kind of not with it mentally, so they're not really making a lot of sense either. And their blood pressure is tanking and they're crumping fast. And they can die from a matter of minutes, and this syndrome, they can present like a spinal cord injury without the mechanism, you know what I mean? Where does the spinal cord get its blood supply from? What if you had a patient, let's work it backwards. You have a patient with a John Ritter. Does anybody remember John Ritter? So he died from where? So if you have an aortic dissection, that can usually, it's going to happen fast, right? Because that's under a whole lot of pressure. So once you pop the skin in one area, it goes whoop, and the zipper opens right up, right? So usually they die, and they die real quick. But you can have a dissection a little further down under the arch. I mean, unless you're already open on the operating table, you're gone, right? That's under enormous pressure, and everything that's coming in is going out and not to the right places. It's just, you're gone, okay? So less than 5 minutes, bam. But if it's a little further down, okay, and you start having a little bit of a tear, it's under less pressure. Again, usually they kind of open up. But say you've just got an aneurysm there, or it's a slow leak, or it's just an aneurysm that's a really big aneurysm, it's not getting blood supply to the spinal cord, you're going to infarct your spinal cord. So they're going to present looking like they have a spinal cord injury, okay? Because they don't have sensation or movement, and they have that rolling out, okay? So this is where mechanism really comes into play. And as field people, the in-hospital people get very, very lazy and don't care about what happened until you get to the ICU and they want to know what the second cousin's former roommate did in college. That's the ICU nurse. Yes, I know. And the ED nurse is like the ADD nurse. Oh, great. What's this? What's that? What's that? I've done all this. So no judgment, okay? OCD as well, Mark can tell you. So, but knowing the mechanism behind is really, really, really important. You guys usually pay a lot more attention to that than the inpatient. Well, I don't care what the original presenting injury was. We only care about now. What's his white count? What's his blood sugar? What's his, crit and all these other kind of sort of things, right? But you guys care about the mechanism. So when you're presenting, when you're seeing something clinically in front of you, always try to think, okay? So it's just kind of maybe another one of those things. Sorry, it was a long talk, but one of those things that maybe would give you a tip. You have somebody with an unexplained, non-traumatic, appearing to be spinal cord injury, and yes, there can be priapism, okay? Don't think spinal cord injury primary. Think spinal cord injury is a secondary injury. Again, it's not very common, okay? But you never know, you might be that one person to see, detect. Okay, so you've got your sympathetic, your fight or flight, okay? We talked about the hypothalamus and how important it was and all these other kind of sort of things. We will not excessively go into the alpha and beta receptors. This, you could sit and talk for, oh my goodness. And I started putting in some stuff here about drugs, and it's just way more than is necessary. And I'm sorry, I kind of geek out about it a little bit. But sympathetic nervous system is really going to be your fight or flight, okay? So what is the one indicator that you get in a healthy 20-year-old who's got 4 gunshots, you know what I mean, to the periphery? There's no indication of spinal cord involvement whatsoever, and you know he's getting shocky. How do they look to you? How do I know from across the room that you are perfusing your brain well? Okay, so the patient looking shocky is going to be pale. How do they feel? Cool and pale, cool, and clammy. Anxious, definitely. That mental status. You're the one that got it like right off the bat. That's the, level of consciousness is actually the very first thing that changes. Oftentimes, either we've done things to them or they've done things to themselves that make us lose that indicator. But your indication of shock in someone usually is, oh, you're not looking good. You're looking the same color as the bed sheet. Can very dark-skinned individuals become pale? Oh, yeah, right? So are their lips bloodless, nail beds, capri, all these other kind of things? That you can tell if someone's shocky, right? I'm sweating. Why do we get sweaty like that? Why do we get pale? Why do we get cool and clammy? How? What's fight or flight? What's compensating? What's the mechanism? Shunting. The blood is going from to my right here, okay? And then first you lose the gut, and then you lose the kidneys, and then you lose the liver, and all that good stuff, right? And that whole cascade sets off your whole, oh my gosh, shock is so much fun, but that's not what I'm talking about. So we're going to go back to this. So that's how you know someone looks shocky, right? If you have somebody with a C6, they'll be breathing okay. C6, transection of the cord, you present, or you go to the field and they're presenting like that. What do they look like? Do they get pale, cool, and clammy? They do not get pale, cool, and clammy. Why? You lose that prognostic, that quick, oh, I look at you and I don't like that. Why? No innervation is left, right? So yes, there's no communication, so they can't clamp down. They don't have fight or flight below the level of the injury. Remember, incomplete and complete are two different things, so I know it goes into it a little bit, we'll talk about it. But just keep in mind that you've lost that immediate, they will have what kind of pulses? Bounding pulses, great big old pulses, okay? Boom, boom, boom. Your 20-year-old, you can feel like in their fingernail, you can feel their pulse. In their earlobe, you can feel their pulse, right? Because they can't clamp down. They look very poofy, right? Because they are in distributive shock. Very, 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 very dangerous. Okay. All right, so we got our sympathetic. So a little bit, when you have, so we're talking really kind of like spinal cord injury here. So stimulation of sympathetic nerves, which can happen artificially, okay? So we're going to say like, i.e. a Foley catheter, okay, or a distended rectum, all right, can, without parasympathetic input, will cause sympathetic overdrive. What does your sympathetic do? Fight or flight. What does your parasympathetic do? Anti-fight or flight, right? So it kind of calms everything down. Your pupils constrict, your heart rate lowers, your blood pressure lowers, urinary output kicks up, you know what I mean? You're no longer running from the bear or running from the dinosaur, okay? So if you have sympathetic without parasympathetic, which is the case, they have nothing in complete spinal cord, okay? And they have some kind of bad stuff we'll talk about in incomplete injury, but can result in autonomic dysreflexia. So AD, this is a very underappreciated outside of the neuro world, very easily remedied and completely preventable almost all the time. Autonomic dysreflexia will lead a very, very, very straight line to dead, okay, in a 20-year-old or an 80-year-old, okay? So what do I mean by that? You're transporting a patient from, usually not fresh, so when you're getting them in the field and going in, you don't kind of have to worry about this, but let's say you're transporting somebody from hospital to skilled nursing facility, and they're vent dependent, they're going to need ALS, right? So, or hospital to hospital, community hospital to trauma center or spinal cord center, right? If that Foley is not, and we're not talking about the bag, right? Nobody cares about the catheter bag, right? If you do, you need to stop it and smack yourself because you should not care at all about the bag. You care about what's going on internally, right? But if that Foley is kinked and they're having bladder distension, they're going to have, sympathetic stimulation, and the body's like, whoa, but the body can't respond to it. The body can't empty it. It can't control its own sphincter. That Foley is kinked. It can't do anything about it, and the guy doesn't even know anything's going on. All of a sudden, he's got a bad headache. You check his vitals, his heart rate's 250, his blood pressure's 250 over 140, okay? He's very flushed. He will stroke, and he will die, okay? And I said man again, but same thing, woman, man, all that kind of stuff, all right? So very, very, very clear progression. Autonomic dysreflexia, they will have a cerebral hemorrhage and then die, okay? It's very, very bad. So we'll talk a little bit about parasympathetic. Remembering that your sympathetic is your fight or flight, your parasympathetic is your, okay, good stuff. You guys are so super duper smart. Okay, so we're talking about what they really kind of do is really kind of sort of slow things down, have a lot to do, okay, with bowel and bladder tone and sexual function, okay? So very brief segue, just talking about those two particular things. People have, an expression that sometimes comes out, well, that scared the out of me. She said it, I didn't. I love it. You know it, right? But if you literally see that, you might have urinary incontinence, but if you have rectal incontinence at the scene of anything, your suspicionometer goes like to 99 on a scale of 100. That's a spinal cord injury because that sphincter usually puckers right up in every other instance, okay? So if you have somebody that loses bowel control, huge suspicion, regardless of mechanism, they have some sort of either primary or secondary, usually primary, injury to their cord, okay? So really, 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 really interesting. And sexual function. So does that mean that somebody who's a para or a quad can never have a kid? Not at all. There are all sorts of, I could tell you some interesting stories as well, things we did at the VA to enhance, okay? So that people don't think that life is over. Life is different, but life is not over, okay? All right, fantastic. Neurologic examination, what are we gonna do? So I underlined one word on this slide, and I underlined it in like the next, like, I don't know, 5 slides or whatever. What word is that? History, 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 history. So in all systems, in all injuries, in all everything, you always need to know history, right? Mechanism of injury, what was going on prior to, oh, they crashed the car, but were they having an MI and that caused them to crash the car? Did they fall off the building because he was high? Did he get shot because somebody was mad at him? You know, history is really important, but in neuro, it's doubly so. We don't care about just event history. We care about prior history, okay? You know how if you get frostbite, you're more susceptible again? Heat and cold injuries? Neuro is like that. If you have a history of a neuro injury, you are more susceptible to another one, okay? It's very sensitive. It's like a teenage girl, okay? Your lungs and your neuro system, brain and spinal cord, they're very, very sensitive. They're easily injured. They're easily offended, okay? So history is super important. What are they normally? Do you have a problem responding to a, motor vehicle crash and the guy can't move his legs and he's out on the grass? Was he a para prior? And some good Samaritan pulled him up. Oh my God, seriously? Yes, that happens, okay? So pay attention. Oh, he's got a... No, he's been a para for 25 years, okay? So remember that it's hard for all of us in our field to remember that they exist as a human being before they met us, okay? Or we met them. So what is their normal baseline? What recent trauma, talking about event history, what has gone on that could affect the nervous system specifically, okay? Did they have a seizure and crash the car? I actually responded to, as a good Samaritan, to a patient who had a seizure. Oh my goodness gracious, would I ever consider doing that again? I'd have to think about it because it tied myself up in court for 2 years because this guy couldn't get his job to pay. He had a seizure, crashed his car. I responded, and he turned out just fine and dandy, but it was a company car, and the company was making him pay for it, and I had to go and get deposed and testify and all these interesting things. I think Law & Order is really cool, by the way. I think it's really neat. I hate all medical shows because they're fake and stupid, and I'm sure cops think the same thing about Law & Order. But it was not fun going through it, and this was like 15 years ago, so it doesn't matter. And I'm going to stop talking about it now. So recent infections, remembering infection, okay? Very, very important. Did you recently have any sort of, I don't know, sinus surgery? That's going everywhere. Ear infections can cause issues. Mouth and tooth infections. So nowadays you can't have a cardiac bypass if you've had dental work done in the last like 90 days, right? Your mouth is filthy. My dog licks his butt and the neighbor's dog's butt and his mouth is cleaner than my mouth. What? And I brush and floss? What's the deal with that? But it's true. So just thinking about all kinds of everything. History with everything is important, but with neuro, it's super duper duper important, okay? History of headaches, migraine headaches. Have you had difficulty concentrating recently? Who has a headache and doesn't want to listen to me anymore? Don't lie. Yeah. So it goes in accordance with mechanism, okay, but history is really important, okay? On any given days, we all, feel like this. I don't know, oops, I almost fell down, and, I didn't hear what you said, those kind of sort of things are interesting. So what do you want to include in your history? This is all common sense sort of thing. Clumsiness, numbness, tingling. When we talk about weakness and whatnot, what is very, very often forgotten in the field and outside of the neuro world, so sometimes even in the ED, sometimes, I'm not going to say that, but sometimes it gets forgotten to be fully assessed. We really look, ow, 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 ow. So they're looking at this arm, and then what could possibly happen? We forget to assess equality, right? So both extremities. So in neuro, it's really important. If I'm having numbness and tingling in my right leg and foot, I need to also not just worry about that one, but worry about the other one as well, okay? You guys are critical. EMS is beyond critical in knowing what the first exam was. because it can change drastically just in the back of your rig, right? But it can change over courses of days. And in hospital, again, we sometimes tend to minimize what happened pre-hospital because now it's the real world, right? The hospital is where it counts. Not intentionally, everybody does that. You care about what you are doing, right? But it's really, really important to have that baseline exam documented in everything, but especially in neuro. With a brain injury, baseline pupil exam. You know, some drugs affect your pupils and some don't. I'm talking about the drugs that we give. Yes, their own drugs, okay? But you know, knowing what drugs you gave, what was their exam prior, and what was their exam after, and then did they have numbness and tingling in their left foot? But I've had that for 5 years on and off. Oh, that's really what's going on. You know what I mean? So the baseline exam is really important. Stop talking about it now. Impotence, and we talked about the really, really bad type of impotence. I'm sorry, I said impotence. Incontinence. Is that fecal incontinence? If you poop your pants, something really wrong neuro-wise. And then impotence. Incidentally, impotence can be something that people are not comfortable talking about, right? Who would love to, you know, just have a whole conversation on their ability to perform sexually. Of course, no one would, okay? And one particular drug, okay, it's a particular class of drugs is given out to lots of males of a certain age who have, you know, a certain medical diagnosis. We're not talking about Viagra, I'm not going there at all. Talking about a class of drugs that has impotence as almost its #1 side effect. And lots of people are on them, and lots of males stop taking them because of this side effect. Metoprolol, yeah, your beta blockers. Did you know that? Ooh, yeah. So if I'm happy and go lucky and now I've got hypertension and they put me on lisinopril, nice little ACE inhibitor initially, and I take that, but then I don't want to get up and pee, or for whatever reason they add a beta blocker, metoprolol. It's really cheap. It's 1,000 years old. Everybody gets it. Very effective too, okay? And a huge side effect that men do not like, well, some men do not like, okay, is impotence, so they stop taking it, okay? And then they have high blood pressure and they have an MI or a stroke, calling you to the scene. Okay, so history is really important, okay? Sorry. All right, so we're gonna talk about vision. Remembering vision really comes from what area of the brain? Occipital lobes, so the back of the brain, okay? So are you having vision problems? Not just let me look at your eyes and are they pearl, okay, but are you having vision problems? Are you having floaters? Are you having diplopia? Whatever it is, okay? Did you do anything or did you take anything? And do people usually give a nice, honest response to that question? Absolutely not, okay? So always, kind of trying to be sensitive to this, that, and the other. I don't care what you do. You want me, I'm here for you. You don't tell me, I'm not gonna be able to help you, okay? I'm not the police, okay? But I gotta know for this, that, or the other. So slight segue, do you guys remember the movie As Good as It Gets? Anybody see it? Jack Nicholson and Diane Keaton. Awesome movie, by the way. So in that movie, he gets a nice young girlfriend and he starts taking Viagra, right? And so then he can, keep up with her and everything's all fun and happy and going on. And, oh, I got some chest pain. So he goes into the hospital and they ask him like, oh my gosh, did you, or they didn't say, oh my gosh. They said, have you taken any erectile dysfunction meds lately? Have you taken any Viagra? And he said, absolutely not. I would never take that. Who are you to ask me? And they said, oh, okay, good, absolutely, because otherwise this drug that I'm putting in your arm will kill you. And he rips the IV out and he sits up and he's like, no, right? Because they're giving him nitro with the, okay, maybe. And then the next time he comes in with the same symptoms, he says, I just took my Viagra. It was really funny, okay? So not judgmental, but important to tell them why you're asking. Right? Okay, great. Troubles with ADLs, check your sample, and you guys are pre-hospital, so you know that, right? Very important acronym. I don't have so many acronyms, but very, 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 very important. And then some, it's last oral or last menstrual period, remembering to ask the ladies that as well. Okay. Let's see, what do we want to look at? Their mental status, their emotional status. Is it appropriate to the situation? You know what I mean? Specific, and we'll get into all of these. We're checking their thought process. What is their general behavior? What is your AVPU score? I was happy to see that you guys have AVPU. Everybody familiar with AVPU? Use it, very, very wonderful. It's a very reliable tool. Translates very easily across disciplines and across countries, and it's great. So level of consciousness on all patients. So it's not just awake or unconscious, right? There's all those little things in between. So are you awake, but are you lethargic? Are you stuporous? Not stupid, okay? But are you stuporous? Are you obtunded? and kind of being able to communicate those to the receiving end, because you're going to take them somewhere always, right? All right, so arousal, talking about arousal. When might a patient have a problem maintaining a level of alertness, or their level of consciousness may be decreased due to, I'm trying to like kind of go back to like, I don't know, 35 slides ago. We were talking about one particular injury that really affects a certain system. They might have a diagnosis, but they might not be able to maintain full wakefulness. That's it, damage to the reticular activating system. So it's because I'm standing close to him that he's getting this osmosis from me. Yeah, it's good stuff. You got it. All right, fantastic. So just kind of trying to, retie things in here and there. So Glasgow Coma Scale. Is everybody familiar with this? It's a good tool? It's a good tool because it's very reliable, not meaning that it always shows up on time, but that you get usually the same score across a trauma surgeon, a neurosurgeon, an EMT, a nurse, a paramedic, a respiratory therapist. Okay, it's a very reliable tool. However, it is a very dangerous tool. We get really comfortable with numbers, like we were talking earlier, right? So you have a GCS of what normally? What do you hope I have right now? Good, and what does the table have? So there's no 0, right? So that's like already kind of like negative. I'm not a real big fan of the GCS unless, and I challenge you from this day forward to always do this, okay? When you get report and you get a GCS, not just asking the score, but asking what particular component of the score, because it can be different. You can actually have a huge change very rapidly based on what component of your GCS, because it affects the total score. So let's back it up. That was too big of a question. Your GCS is, what are the things that we measure in a GCS? Score of 15. Eyes, verbal, and motor. Good. Okay, so now this is someone else's, and I actually don't like it, but other people seem to like it, so I'm going to pass it along to you, okay? So how do we remember what this, that, and the other? Maybe you guys already know, and you don't need it anyway. But EV and M, so your extra value meal, is $3.56. Have you guys heard that? It's not, by the way. It's a lot more than that now. It used to be. When I worked at McDonald's and we made the biscuits by hand, anyways, but GCS, eyes, verbal, and motor. So what's the perfect eyes? And the verbal is, and then the best score is a 6 for motor. What does that mean? What does a 6 mean? Obeys simple commands or normal complex commands. So I'm not asking you to do quantum physics, or go backwards. I know the mini mental exam, but I hate, try to find the average person and ask them to sequentially count backwards by 7s. What? Okay, so don't necessarily count it, but anyways. So I'm not talking about something really complicated, but are you oriented times 4? Very good. So that is the new norm. Your book does not really reflect that yet. It still says times 3. I did add a little spot in there. It should be times 4, okay? So below, following complex commands, you should be able to show me 2 fingers. Take your left index finger and touch your nose. A complex command, but that's not too ridiculously complex. Underneath 6 following, and don't ever say, show me thumbs up. This is a very common, frequent problem. Doctors are notorious for doing this. Show me thumbs up. What did you just do? So if they then do this, 90% of our communication is nonverbal, right? So if I go in and go, you can't understand anything I'm saying, but you know what I want from you, you're going to do that too, right? So absolutely do not demo anything for them, okay? Give them a complex, close your eyes. So you see how you're making eye contact, you're doing that. Sorry, I don't mean to pick on you like 3 times in a row there, but so a complex command, but do not demo it for them, okay? But then the number 5 is what? Localizing. So what does that mean to localize? To be able to take an extremity and try to remove, a stimulus and try to go directly to that stimulus. Usually the rule of thumb is to cross midline and try to remove it, okay? So we want to see people grabbing for their ET tubes and grabbing for their, yes, the boys do it more than the girls, but it's still not comfortable, so we want that, right? We want to have to tie them down and drug them into submission, right? No, I didn't mean that. I just meant that, we want to see that because that's a good status. You can't talk to me, you got a tube in your mouth, I want to see you try to rip it out. You don't like that, right? Localizing is good, usually crossing midline, okay? So not pinching here and trying to get them to grab you here, pinching over here. You want a good brisk response. That's a number 5 on the motor score, right? What's a number 4? Withdrawing, I love it, fantastic. What does that mean? Demonstrate that for me, please.
Trying to remove their body from the,
So, yes, not trying to go towards it, or it's a non-specific action, non-specific. So like even if I'm pinching right here and my hand's right here, you know what I mean? But it's not able to be specific to that area, okay? So you pinch their arm, it's what I want to see is the other arm come over and grab me, right? But this, they're just like going, so they can feel something, but they're not, you know, good enough to be able to go up and get it. That's a 4. What's a 3? What is it?
Moaning and groaning.
Well, that's verbal, okay? So it's actually, I think it's a 2 is, can't think, posturing. So flexor and extensor posturing, decorticate, decerebrate. So flexor is the new term. I don't know why we had to change terms. Decorticate, you demonstrated it. So everybody do decorticate. Decorticate. So you're going to the core of the body. You're trying to come inward. Toes can kind of, you know, flex upwards, and the knee might bend. Okay, and we really grade all of these movements on the upper extremities, right? We kind of don't care what the lowers do, right? But this is important. So are they flexor posturing or decorticate posturing? What's the number 2? Extensor or decerebrate? Extensor or decerebrate? So demonstrate that for me. Good, so we're stretching because we're really tired of being in this classroom, it's hot and all this other kind of stuff. Okay, so decerebrate, okay, so you might see a twisting out, okay. They might really rigidly kind of do that, often with a right or left deflection of the head as well, and the toes very frequently will point downward, and you'll have a very rigid extension of the legs. Decerebrate posturing, you have brainstem damage, okay. Do you come back after you are to mowing the lawn and going back to work if you are extensor posturing? No. You don't. You might come back to a certain extent, but no. Brainstem involvement, really serious, right? I mean, it's all really, really serious, right? Okay, and then a number 1 is, yeah, and why are they none? Did we paralyze and sedate them and try to get an exam? Don't do that, okay? Do you ever give somebody a bunch of drugs and then have somebody go in there and try to get a reaction? That's not nice. Don't do that, okay? So don't let anybody else do that to your patients either. But anyways, so can you have mixed, this is why motor is so important. Can you have mixed items on either side? This is why the score is very, very dangerous sometimes. A GCS of less than 8, then we have to, I thought somebody always fills it in, you make me very happy, thank you very much. So we have to intubate of a GCS less than 8, that's pretty much the rule of thumb, right? So your thumbs up, everything's all good with a GCS of 9, right? Maybe, because their motor could be the difference, okay? The motor score. I in verbal is what it is, okay? But motor, I could be localizing on this side, and yes, I could possibly be flexor posturing on this side. You can have, it's not common, but you can have a 2-point difference, okay? But I could very easily, and frequently happens, withdrawing on this side and localizing with this arm. That's my 1-point difference. I have 2 more cc's of blood in that bleed, my epidural, you know, that's continued to bleed now, and that drops my GCS, and now you're trying to tube in the back of your rig. Is that a very easy thing to do? You guys will be, if you're not already, okay to intubate, right? Do you or do you not? Okay, good. So is that a pretty easy thing to do? No, absolutely not. Whether it's a king tube, nobody's using combi tubes anymore, right? Really? Okay, all right. So but whatever you're using, that's still hard to do, right? Even if you don't need to be able to visualize chords, do you? It's still hard to do. So get the, I challenge you, get the motor, so I've got a GCS of 13, what's their motor? Oh, he's a solid 5 on both sides. Okay, well, with 13 he would be a 6, you know what I mean? So just, I challenge you, and always, your receiving department, the physician and nurses in the ED that you're going to transport to, or the unit if it's a direct admission, will be very, very impressed with you if you provide them. His GCS is 10, he's got a 5 for motor on the right and a 4 for motor on the left, and they're going to look at you like, like that, like just, you take a picture. Okay. Don't be reassured by the score. Yep, that's AFPU. You guys already know that, so I won't talk about that. Okay, great. Okay, so physical exam, we've got, here's where it is, you know, alert and awaken, alert, and oriented, times 3. No, it really should be times 4. So person, place, and time, and then situation. And don't ask them the standard stuff, right? What's your name, what's the date, and who's the president, and where are you? come up with something different, because they will be very accustomed to hearing those questions, right? Not if you catch them in the field, but if you're doing transport facility to facility and you need to do an exam, they're gonna, have been asked those things about 75 times. So, mini mental exam, right here, there's a couple of slides on it. These are tables within your book. It really kind of talks about, for level of consciousness, this is often, you're awake, you're lethargic, or you're unconscious. No, there are levels in between that, okay? So just kind of, it's good to be a little bit more familiar with more than just, I'm doing fine, I'm not fine, or I'm dead. Kind of getting those nuances in the middle there. So obtunded, being obtunded, something's probably going on, but you can be obtunded from not a brain injury, but from, all that heroin. Holy cow. That's a big thing in our communities now, isn't it? It really is. Parent of a teenager who doesn't do drugs, I think. I'm pretty sure. But the high schools are having like all these talks about it. I didn't think, really? It's expensive, isn't it? And it's a downer, but anyway, enough of that. Patient orientation, so here they have time, place, and person, remembering situation. Where are you? Well, I'm in WCTC. Why are you at WCTC? Can you tell me about it? Oh, I'm here to take a class today on this stupid neuro lecture that's never ending, and it just keeps going on, and there's so many slides I can't handle it anymore, that kind of thing. So why are you where you are, okay? Why were you in the car? Because that's a very early indicator. That'll go away first. I'm in the car. I'm on Highway 16, Oh, but why? I was going to WCTC, that's right. But, so the earlier you can catch things, the better. And here's your mini mental exam questions. I get really, really, really furious with some of these. So this is very difficult for lots of people to do, okay? I know it says by sevens. It's a little easier to have them count sequentially by threes. And you can still get, it's still kind of more than just count to 10, But so sometimes I will ask them to go backwards by threes, things like that. But the registration and recall is very good, very important. Have you ever been present when someone else was trying to do this and then you try to remember? So somebody's in the room and they're saying, hey, remember bottle, computer, and pen, okay? Bottle, computer, and pen. Can you repeat those back to me? Thank you. Hello. Okay, so that's our registration. Do you understand what I'm saying, and can you parrot it back to me, and can you regurgitate it, okay? And then all these other things. We've got language. What is this? What color is my shoe? Did you notice, by the way, I put on bright white shoes for you guys today? Yeah, I changed that on my boots. I was going to leave them on, and I figured I would trip and fall and be embarrassed. So that's actually really why I changed. But look, they're bright white. Yeah, they're pretty good. I haven't stepped in poop yet with them. All different sorts of kind of things. Okay, so now we're going to talk speech function. So what I did is add this little thing over here of language. Everybody assumes all this that I'm doing right now is speech. It's not. Speech and language are different, okay? You can have dysarthria, which is different than dysphonia, which is different than aphasia. And there are no fewer than 4 types of aphasia, right? Aphasia is not aphasia is not aphasia, okay? Can you guys tell me what those 3 items were that I said to you a few minutes ago? Thank you. But you all had a little bit of a minute there, didn't you? It's hard. And usually they let more time than that go. They'll let like at least 10 minutes go and then want to know again. It's very interesting. Some people can only get 1 or 2. Do you ever watch that show Brain Games on National Geographic? Oh, you totally should. It's so interesting. Yes, I absolutely love it. But it kind of shows you how lowly functioning we all are and how much by routine we function most of the time. You ever driven home and not remember doing it, but you got there okay? Yeah, we need to pay attention. Night shift. Don't judge me. Okay. All right, but we're going to talk about speech and language, okay? So dysfunction in any component or process of communication, okay? Aphasia. Aphasia equals language. And this is very, very misunderstood outside the world of the neurologist, okay? We all do it. You have all done it at some point. So somebody, we want you to repeat back. What's that sentence we always want them to repeat back? Can't teach an old dog new tricks. No ifs, ands, or buts. Today is a sunny day. Today is a cloudy day. Those are the big sentences that we want to hear them say back, okay? And so what? You couldn't understand what I said, so you're going to say I'm aphasic? No, I may have dysarthria. I may have a trouble actually articulating the words because I have muscle problems, but my language function is still dead on. And how do we assess that? Without me demoing it for you, I would like you to take your left pinky finger and raise it high in the air, and then touch your ear, and then touch your nose, please. And I'm making eye contact, so I want you to do it. Oh. Ah, very good, but you did it backwards. As you touch your ear and then your nose. Oh, it's horrible when you're around a neuro person. It's so annoying. I fail that a lot too, don't worry. But that's how you're assessing everything. Dysarthria is not the same thing as aphasia. Don't classify those. And frequently we say they're aphasic when they're not, okay? And if they are aphasic, they are, but we need to know what kind. Okay, so we have, oh great, okay. So we have, here we go, dysarthria, articulation. That's the mechanics of speech. That's a muscular issue, okay? So you can be completely unable to express, and that's expressive aphasia, or you can be okay if you really understand, because my floppy lips and my floppy tongue now aren't cooperating, that I'm really saying no ifs, ands, or buts. You know what I mean? Okay, all right, that's enough of that. To assess cranial nerves, how many cranial nerves do you have? 12, fantastic. So they're very, very easy, but you have to have participation in order to assess at least the first one, okay? Not all of them, but the first one. Your olfactory nerve. So who's got a good mnemonic? Let's hear them. There's always such interesting ones to remembering what the 12 cranial nerves are. Okay, but really, it's more important that you know rather than remembering the exact name of it, because the glossopharyngeal one is one that we kind of sometimes forget, but trying to remember how to assess for them, right? Olfactory. How do you assess someone's olfactory nerve? You have to be awake and coherent enough to participate in this. So if you see any documentation, cranial nerves, blank through blank intact, 98% of the time it's going to be cranial nerves 2 through 12 intact, okay? Almost, and only in a clinic should someone really be writing 12 cranial nerves intact, because no one takes the time to go get, I mean not no one, but really no one takes the time to go get something to help assess their level of their olfactory nerve, okay? But if you happen to be checking somebody in the home, remember that if you're testing their olfactory nerve, you cannot let them see. You have to cover their eyes. But citrus, oranges, is a very, very good one, okay? And a lot of people have oranges around the house. Okie dokie. Okay, your optic nerve. So are you Pearl? Okay. So when do we start freaking out? We've got, oh my gosh, there's a bad brain injury going on. Something's happening right now. We got to get this guy to the hospital so they can get him into the OR like super stat. And it has to do with cranial nerve number 2. What happens? What doesn't work anymore? Pupil contraction. Very, very good. We get all freaked out when suddenly someone has a fixed and dilated pupil, right? That's a pretty good early prognostication, right? Is that a pretty good early warning sign? No, it's not. Huge frowny face here, okay? You guys nod along because I'm nodding and you've checked out mentally, haven't you? I don't want to see it. It's really hot in here. It's hard to stand here and talk to, okay? No, you have missed the bus, okay? It is a very late sign of neurological compromise. You at this point have pressure, barring any baseline issues, okay? So we're not talking about somebody that has, issues prior. We're talking about, oh my gosh, they were working and now one's not, or both are not, okay? It's very late. That's the person that's already going, I know that was not very attractive. I'm sorry about that. But that's really bad. Why does that happen? You have pressure on cranial nerve 2, okay? So pressure from what? From either swelling, from blood, from pieces of bone if they have a depressed skull fracture, anything like that. A tumor, a lesion, okay, could be causing the pressure. And suddenly that pupil will not constrict anymore when exposed to light, okay? So we care about Pearl, but what we really care about is, are they as Pearl as they were an hour ago or 2 hours ago or yesterday or 10 years ago, okay? And we'll talk a little bit later about, it's not in this one I put it, what we do to fix that if it's not working anymore, okay? So optic nerve, remembering to look at both eyes. And to be honest, so pupil exam is part of it's not part of the score in the GCS, but it's part of the GCS, right? So remembering it's eye, verbal, motor, but also check the pupils and then be honest. I don't know if that's working or not. If someone comes to you really, really, really high and they've had a lot of drugs and their pupils are this big, can you assess them? You've seen pinpoint pupils? Do they contract? No, sometimes they are maximally contracted already. So don't write Pearl if you haven't seen it contract. You're not telling them what they are, you're just saying what you see. It's okay to be different from someone else too, okay? All right, so then you've got your, this, you know, O to touch and. So 3, 4, 5, and 6 usually are examined as a group. So that's, you know, follow my eye, follow my finger, you know, all that kind of like goodness. Position of the eyelid, checking for lid-ptosis, not ptosis, not like pitocin either. Okay, all right, sorry, I'm sorry. Really watching for nystagmus. So this is an extra one here. So nystagmus is really, really a really good indicator that something pathological is going on in the brain, okay? And it can be a very early indicator. I do know one human being. I have met one in my entire life, and she's really weird. So I don't know if this is like her makeup or what, but she can demonstrate, she's perfectly normal. She functions, she's an ICU nurse, afraid of her, and she can demonstrate lateral nystagmus. It's the weirdest thing in the universe. Okay, I've never met anybody that can do that. So what is nystagmus? Bouncing. They either bounce back and forth. She can demonstrate horizontal or lateral nystagmus, or there's vertical nystagmus as well, okay? And depending on what type it is, that's why you need to watch. Do they bounce back and forth, or do they bob up and down, or do they bounce up and down? You know what I mean? Because that can tell the, and knowing you're the first, you're the baseline, that can tell the neurologist a lot, okay? And then they'll, you know, maybe do this, that, or the other exam quicker, radiologic exam quicker than they maybe would have, okay? So everybody gets a CT, but in some cases an MRI is warranted, okay? All right, your facial nerve. Beware, facial nerve, cranial nerve 7. It's a lot of fun. So let's say this. I'm gonna go over to, this is a really good, again, people will really be super duper impressed with you. So let's say you go over to respond to a call down the road, and you go into the house, and it's an 82-year-old who says, I've got a really bad headache, and she's 82 years old, and vitals are fine. So you do a fast exam, right? Everybody knows what that is. I'm really excited that I'm not talking about a fast for trauma and ultrasound, not talking about that. They're starting to have commercials for this out on the radio, which is why I'm kind of testing. American Stroke Association is doing it. FAST stands for face, arm, speech, and time. So that's kind of where I'm going with that. So it's a very quick, I know there's Cincinnati pre-hospital screen, and then there's like 87 pre-hospital screens we'll talk about. Can't remember which one is in your lecture, but there's a ton of them. American Heart uses Cincinnati. I'm really blanking. I think it's Los Angeles. I can't remember, sorry. But we'll get to it. But you do a quick face assessment, and she smiles and goes like this. She's 82. She smiles and goes like that. She's got a bad headache. What do you jump to instantly? Don't lie. She's having a stroke. Absolutely. So after working up and you know, really quick doing what you're doing, you package her up, you get her, and you tell Grandpa to come with son later on. You get her over to the hospital, and they are going to diagnose her. They're going to quick do a CT scan, and you think they're going to give her what? TPA, because you're thinking she's got a stroke. They do a CT scan, and they say, holy crap, what else happened to you today? And she says, oh, I was, you know, going downstairs to get some preserves from the basement, and the dog ran through my legs, and I tripped and fell down the steps, okay? Yeah, I know I'm taking a little bit of liberty here with the scenario and whatnot, okay? And she fell down a couple of steps, okay? She has a basilar skull fracture. Facial nerve, cranial nerve 7 is your facial nerve, and it runs through, and certain areas prone to fracture in the ring, just like your pelvis is a big ring. I have a nice picture of it later on. The base of your skull, if you're looking down or up through it, should be a nice ring, and depending on where the fracture is, it can pinch facial nerve, cranial nerve 7, giving you a facial droop. Don't always assume that the old person with a facial droop has a stroke, because it could very easily be a basilar skull fracture resulting in a facial nerve facial palsy, okay? How do you figure it out? Who's ever done an NIH stroke scale? Oh my gosh, that 40-item exam. It's really painful. But they ask you to do all sorts of things. They want you to raise your eyebrows. They want you to wrinkle your forehead. They want you to close your eyes really tight. They ask you to do all those things, and this is how you determine whether or not they've had a stroke, okay? It's a little bedside thing, not well known, hopefully. Hopefully I'm going to show something new in here. So you want them to wrinkle their forehead. Please wrinkle your forehead for me. Some of you are already doing it already. Okay, you can go down or up. And you got the lines kind of like there. I usually wrinkle down like this. What are you talking about, Willis? Okay, all those other kind of things. All right, so you wrinkle the forehead, but a lot of times try to wrinkle it upwards, okay? And then have their eyes closed, smile, but wrinkle the forehead. If the forehead wrinkles on the side of the paralysis, so if I smile and go like this, okay, and this side isn't working, and I raise up my, wrinkle my forehead up or down, and you can see that it's wrinkling across both sides, okay, you have a stroke rather than a facial nerve palsy, okay? And the reason is that the central root of the nerve gets blood from both sides of the brain, okay? So if you have a stroke, that nerve is, this part of the nerve is being, damaged, it's not working, so that's why you're having the facial nerve, or the facial issues, the facial droop, but the forehead part will still work on both sides, and that's part of the reason why on the NIH stroke scale, they have you do both. You get a point if you can smile, you have to close your eyes and raise your forehead, and eye closing and forehead wrinkling is a separate line item than the smile, okay? Does that make sense? It's kind of cool. Okay, let's move on. Number 8, vestibulocochlear nerve. So, has anybody heard of a test called the cold calorics? Okay, so don't judge, but we work in a facility that's large. We have lots of levels. I work in a facility that's large, and we have lots of levels of physicians, and sometimes doctors, just like EMTs and paramedics and nurses, can be really stupid, right? And we had a couple of residents several years ago, this was, and one of the first years decided to, well, I really want to see what cold calorics feel like, okay? What that is, you're stimulating the vestibular cochlear nerve by inducing ice water, pushing ice water into the ear canal, okay? So in order to do that, we're not going to do that in the regular person. How do you test cranial nerve 8 in me right now? Have me close my eyes and put your fingers next, or some clothing or something like that. Close my eyes so you can't see which one, and tell me, am I rubbing outside of your left ear, your right ear, both ears, neither ear? That's how you test it in a normal person, okay? But in a person who has severely altered level of consciousness, what we're looking for is eye deviation, okay? With the stimulus, what we do is we put it ice cold ice water directly into the ear canal, and then we will see eye deviation. That's a good thing, it's a bad thing. We won't go into that excessively. However, in a conscious person, what you get is, take a guess. Just really take a guess. What do you think happens? Vomiting? Yeah. You get really bad things happening. So you have instantaneous everywhere. It's really bad, okay? They vomit all over the place. So next time you're at a party and it's boring, say, oh, I learned this really cool new trick, and do it to somebody you don't like. No, I'm sorry. I mean, do it to not that, okay? But they barf everywhere and they fall down because you have seriously messed them up, okay? But we are looking for actually eye deviation. It's a true medical exam, and it's required actually to check cold calorics when you're checking for, it's one of the requirements for one of the pathways of brain death when we're assessing that. But okay, that's that's cranial nerve 8, okay. All right, so let's go on. We're going to talk about our glosso means tongue. Yeah, it's kind of a fun word that doesn't really, thinking of tongue is like a really gross thing. No, glosso. So glossal pharyngeal, so swallowing and tongue and whatnot, your vagus nerve, all those kind of sort of things. Very, very easy and usually quick, and the doctor does this to you all the time. Open your mouth, say ah, and you want to see the palate rise and things like that. Checking for swallow, and that's just checking muscular movement and stuff like that. Okay. All right, your spinal accessory is very easy. You probably have had this done. You may or may not have. Some primary care docs are more, thorough than others, but you turn and have them push against, okay? And you have to do it both sides. Remember, both sides, okay? It's always equal, both sides, and trying to see. So hypoglossal, so this is below the tongue kind of sort of thing. So we're really checking the tongue, okay? Especially underneath. So your tongue and cheek, you may or may not have had this. So tongue and cheek is like a funny way. It's like saying, oh, I really don't, it's a double entendre, right? I'm saying, well, that's a nice chair. So I'm saying something else that's tongue in cheek. Does anybody ever? Okay, thank you. Fine. But this is really how you check it. Okay? Providing pressure, see can they push against it. You have to check both sides because it's not just open. Gum in my mouth. But does my tongue want to deviate that way? That's not good. And that will be present in stroke patients, okay, some of the time depending on where the stroke was. But it's not just checking for drift. It's actually can you respond to pressure, okay? How strong are you? Okay. All right. That's your cranial nerves in a nutshell. Okay, so motor function. We will check all parts of range of motion, normal range of motion. Remembering that certain patients will not have full range of motion. So those baseline exams, what do you do normally? How is this normally? Okay, abnormalities are spasticity. Flaccid extremities are obviously a bad thing. Rigid and spastic muscles and rigid muscles are different, right? So rigidity is an absolute locked, you know, there, but a spasm. When can a quadriplegic look like he's running down the road? Can that ever happen? Maybe not down the road, but oh yeah, long-term quads, they can have muscle spasms that are so bad, those legs are jumping in the bed, okay? So it has to do with nerve response and reflex response, okay? Depending on the type of injury. So spasticity is also a bad thing. I'm not a spastic person. Okay, anyway, sorry. Assessment of sensory. What is one thing that sometimes a lot of us do is we equate motor and sensation as the same thing. They're not. They're completely different. It's like the spinal cord and the vertebral body, okay? So can you feel and not move? Oh yeah. Can you move and not feel? Yes, you actually can. We'll talk about central cord syndrome and what that is, okay? So their sensory is testing the patient's ability to perceive, and they do not get to cheat. It's, I'm feeling your toes. I'm going to point your toe up or down. You tell me where I end up. If I end up with your toe pointed up, I want to hear you say the toe is up. And eyes closed always, they can't cheat, okay? And if they can, you know, tell if I'm touching right or left leg, but they can't, and they can tell if I'm touching the right or left foot, but they can't tell if the toe's pointed up or down. These are all different dermatomes, okay? The level of dermatome involvement is crucially important in spinal cord injury. The physician, the neurosurgeon wants to know that, okay? We want to spare every dermatome we can, because that could be the difference, ultimately, the difference between a sip and puff wheelchair and a chair that I can knock with my arm and still have some movement, okay? What should you do, Mr. and Mrs. Fancy Pantses? You should examine pain, temperature, and touch, okay? So you're going to put the, I was Joan of Arc in my former life, lighter under their hand. Of course not, absolutely, but do they feel warm? Do they feel cool? Is it the same on both sides? So patting down. Remembering that a patient with spinal cord injury is not going to get incomplete or complete to different degrees. We'll talk about shock in a little bit, but they are not going to usually get pale, cool, and clammy because they cannot mount that response anymore, okay? Reflex testing. Very, very briefly, deep tendon reflexes or DTRs routinely are done by physicians, honestly, okay? We will do some of them, but as pre-hospital and in-hospital providers, but primarily, really, this is a physician's like realm, okay? And they gotta do it, and they really, really care about it a lot. We care about everything as well. Okay, so examining the DTRs will tell us lots of things about the spinal nerves and what might or might not be going on with lesions, possibly within, with bleeds, with edema in the brain. We talk about, you know, the PONS and stuff like that. Okay. Tendon reflexes can be increased, which is more seen like spasticity, okay, or rigidity in upper motor neuron, and then you are going to see like atrophy and wasting in lower motor neuron lesions. I'm going to cap it right there because upper and lower motor neuron disease and lesions, we could sit and talk for 10 years about, really, for like 2 whole days about it, okay? Very confusing and truly beyond this, not really relevant to any of us as first-line providers, okay? But if you're ready to go to medical college and, you know, start your neurosurgery residency, you'll need to know them. Okay, so there's smiley and bad faces on here. So pathologic reflexes. Pathologic is good. It is a question. Pathologic is good? No, pathologic is bad. You're like my favorite one there, okay? I'm serious. But no, pathologic is bad, okay? No. But usually pathologic reflexes, we want to see certain things, we don't want to see other things, but pathologic, no, it's just meaning like the what's behind it, that kind of sort of thing, okay? Plantar response. Please describe for me, I have a smiley face there, so you can tell I'm being honest there, I'm not faking you out. We want to see a plantar response, okay? What is a plantar response? And it's very closely, the book had like multiple definitions for exactly the same thing. So sometimes these are the 2 most common ones that you'll see. They had a plantar response. Good. So flexion downward, curling downward. Okay, so you're both exactly right. And do you want to run it right up towards the ball of the foot? Wish I had a foot. So you want to, no, I'm not even going to crank my leg up on this thing. So pretend these are my toes and this is my heel and this is my right foot. Okay, so it's like this is my arch is right here. So you want to run it like this, up and around. And usually, always more than once, usually on an inward basis as you do them in succession, okay? So you want to see, you're scraping, and you always want to use a sharp object. So you don't use the nice toothed, okay, because we all have sensitive feet. Nobody likes to touch our feet or do anything with our feet. Everybody hates feet. But you want a sharp object to be able to really, elicit this response. And a normal plantar response or a negative Babinski's, okay, is how usually we document it, is you will run it up and over, so under the toes. You don't stroke the toes, but you stroke the sole of the foot in a movement like this. So remember, this is my arch here, okay? And so 1, 2, 3 times, but at least 2 times. The first time more outer, the second time more inner, okay? So more lateral and then more medial, okay? And you want to see my toes flex, big toe especially, curl under, okay? So if my big toe flexes upward, that is a Babinski sign. Normally now all we do is we call it Babinski. It's either positive or negative. We've got a positive Babinski, okay? That's a bad thing if you are greater than 1 year old. So what if you're 6 months old? It's normal because your body is still developing, your brain is still developing, okay? Everything is still developing. But by 6 to 12 months old, so even like a year, you know what I mean? But if you are 10 years old and you have a positive Babinski, bad stuff's going on in your brain, okay? So that's a sad face there. Grasp and superficial reflexes, there's actually a separate slide for each one, so we'll kind of go into that. So the grasp reflex, this is something that sometimes we unconsciously help our patients, which we need to not do. It feels mean, but you need to not help them out at all. Don't say, give me a thumbs up, okay, right? We talked about that. That's bad. Don't give them any help at all. We want to see them struggle. Hopefully they won't struggle, but we want to see them struggle and then get it, okay, because that means things are just delayed, but they're still happening. But you will place your fingers in their hands. So this is an infant grasp. Your grasp reflex is one of your very, very basic ones. You go and see the baby and you're like, oh, you're so cute with their little hands, and their whole hand takes up my, just around my one finger, and I don't feel like I have fat fingers, you know what I mean? But their whole hand is wrapped around my finger. Yes, that's an infant, that's a very, very basic brain response, okay? So they will grab it. They don't like you. They don't know you at all, okay? Well, they can know you a little bit, your smell and everything like that. But normal response is to grab here, but they have to be able to let go. So you don't count, squeeze my fingers. That does not count, okay? Doctors will, worked with dozens of neurosurgeons, hundreds of residents over my career, and my career is a long way to go yet. They will say, follows commands when they squeeze my fingers. No, do not give them credit for that. No, you only get credit if you let go, okay? So, and don't help them out. Don't pull away, all right? I know they're saying pull away. Just try to get them to command to let go. And if they don't, then pull away and see if they let go. And then they still kind of get credit, you know what I mean, if they can let go. But the grasping does not count, right? Because that's a baby reflex. A 2-day-old infant will do that. Okay. So, but if I keep going, you pull away from a baby and he's going to, it takes a lot. You sometimes have to wrench your finger out, or your finger out of their hand. Okay. So I have 5 years of pre-hospital, 17 years of in-hospital experience under my belt. 7 years of that was full-time in a neuro ICU at a level 1 trauma center. I have never performed this exam, ever. Have any of you? Let's read this. It feels a little personal, and I do all kinds of things to all parts of people's bodies, right? These things are just like elbows to us now, right? It's whatever. It is. It's just like your wrist or your knuckle or whatever. You don't see it. But I've not ever done this, so I can only read you the slide. Okay, so I have also never seen a physician attempt to elicit this response. That does not mean it does not happen every single day, and I've just never seen it, but okay, we're going to move on. Meningeal irritation, and why do we care, and what do we want to do about it, these kind of sort of things. Okay, meninges, your meninges, meningitis is a really, really bad thing, right? So meningitis, you know what that is now. Itis is an inflammation of the So inflammation of the balloon, right? So that's kind of great. Okay, so it can result from all sorts of things. We really need to identify the causative reason. So the causative agent, if it's a bacteria, if it's a virus or whatever. Viral things like herpes encephalitis is like really, really bad. People think about meningitis, but meningitis can, in some cases, bacterial or viral, some cases can be treated. Like herpes encephalitis is just more like a management of it. There's no real cure for that. All the acyclovir in the universe, it's kind of, is it gonna, is it not? So we really, really, really don't like it when our balloon, our meninges, okay, so balloon around the brain, gets irritated, okay? Often you can see meningeal irritation as a direct side effect several weeks, days to weeks after a patient has a subarachnoid hemorrhage. So we're thinking about subarachnoid hemorrhage. Now, almost all of those come from an aneurysm bursting, okay? So a hypertensive crisis resulting in, they pop their aneurysm, they have a subarachnoid hemorrhage, okay? All sorts of things, we could go on and on about that. But a traumatic subarachnoid is possible, okay? So you'll have somebody that crashes, spiders windshield, falls out of the car, hits the tree, whatever they decide to do, and they've got multiple things going on in their brain. They've got bifrontal contusions, they've got a left subdural and a left traumatic subarachnoid. And they will usually always, I won't say always, almost all the time they will identify it as a traumatic subarachnoid versus a subarachnoid, okay? Because it's not the result of an aneurysm burst, it's a result of a vessel rupture, but it's from trauma. You smack something hard enough, it's going to have issues, right? But after, it takes up to 10 to 12 weeks for blood to be broken down and reabsorbed, but it starts at about 7 to 10 days, your body starts breaking down that blood, okay? Because blood clots right away. Up here, just the same as it does as if you have a little scab here on your forearm, right? So as this blood starts breaking down, it releases enzymes that are excruciatingly irritating to the meninges, okay? Resulting in all sorts of bad stuff. You can get vasospasm, you get photophobia, huge hallmark, bing, 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 bing. I cannot tolerate anything, any light whatsoever. And then they can also irritate the meninges, be one of the causative agents of meningitis, okay? Not usually to that level, but it just gives the worst headaches. These are not drug seekers. That is not a real diagnosis, right? But these are not patients that require 100 or 150 of fentanyl every single hour, and they're asking for it at 45 minutes because they are just seeking out a fun stay. They really need it because it is that excruciatingly painful, okay? I'm talking a lot, okay. All right, so we kind of talked about all this. I think we're coming to the end of something and getting ready to segue into another. Nice hairdo, by the way, but you can see his skull, his brain. All right, respiratory system, abnormal, oh yeah, because the brain rules everything. So if you are having brain injury, you need to be very, very aware that you will likely need, brain or spinal cord especially, you will need aggressive airway management, okay? Be on top of that right away. So there can be absolutely no airway problems, but big ventilation problems because you cannot protect your airway, okay? Just remembering we have all our non-invasive options and our minimally invasives, so we have BiPAP, and then we have oropharyngeal airways, nasopharyngeal airways before you have to go all the way to a ET tube, okay? Rate and rhythm and characteristics. So inspiratory and expiratory phases. Okay, so a C4, a C3 quadriplegic patient, fresh injury. Are they going to be breathing in the field? Okay, let's make it C4. It's a C4 injury. Are they going to be breathing? Not the plastic explosives. They can breathe. How will they be breathing? Not well. How? Demo for me. You're right, it's not well. What do you think? Is it like that? It's not. Is it? Yes. So it's going to be more like panting, right? So they can have a decent, and remember they don't clamp down, so they can have a decent, what's that thing we put on their finger and we're really reassured by a number. It's the most useless piece of equipment in any facility anywhere ever. I'm serious. That pulse ox, right? It'll be like, because it just reflects off of how much blood. That's purely what it is, okay? So it can be good, or you've got your carbon monoxide or your myasthenia gravis patient who dies with a pulse ox of 99%, you know what I mean? So don't just get real, yes, it has its place. I'm not being like that. But making sure to pay attention not just to the number, but the rate and pattern, because this, you're not expelling all the way either. You're not inhaling and not expelling. So what, some air is changing up here, but what's happening to the majority of this dead air down here? What hangs out if we don't? CO2, a hypercarbic patient, meaning a high CO2 level. What's a normal CO2 level? 35 to 45. So hypercarbic patient, this can happen relatively quickly in a healthy, person who's not used to it. We're not talking about the 90-year-old COPDer who, oh my God, don't give them 2 units or 2 liters of oxygen because they'll die, whatever. But kind of going on with your panting respirations, your CO2 is climbing, your CO2 was 45, now it's 55. They still look nice and pink, okay? And they still have some circulating oxygen, so their pulse ox may be reading 94, 95%, okay? But the hypercarbia is going to cause what mentally? As your carbon dioxide goes up, your mental status goes where? Down, right? Definitely, okay? So it definitely goes down. So trying to keep in mind that it's not just this number. You are critically important in watching how they are breathing. Is it 25 times a minute? Well, that's still kind of a normal number, right? But is it 25 panting breaths or 25 real breaths, okay? So you may need to intervene. All right, so the patient's heart rate could indicate neurologic injury. We're really talking about cardiac decelerations. Those are really big, scary things because remember the heart or the head rules the heart, okay? You should pay attention to tachycardia and any other kind of arrhythmias, okay, definitely. But tachycardia is going to be present in how many trauma patients? Like almost all of them, right? In how many patients? Lots. You're not trauma. I mean, still, you're kind of nervous, so your heart rate kind of goes up, right? Bradycardia is suspicious, definitely, in your trauma patient. What if you have an 85-year-old trauma patient? Ah, there you go. Depends. Because of why? You just said it. They're beta blocked, right? Everybody's on it. Let's all give them all a statin, a beta blocker, and an aspirin. Everybody gets it now. The Holy Trinity. It's great. So kind of moving on and knowing that your heart rhythms, I know you guys already know this, but really kind of watching them. But in spinal cord, why do they get bradycardic? No fight or flight, no sympathetic, okay? No innervation. So their heart rate will drop because of that, okay? All right, we've got high blood pressure. Oh, this is good. This is a wonderful, wonderful triad, the Cushing's triad. I know I've got a lot of fun things, but Cushing's triad is my favorite triad. It beats Beck's by 1.5 miles, okay? Cushing's triad, you gotta know it because it's really bad if it's happening, and it can happen over a series of minutes or a series of hours, okay? So it is, what are they? What are the 3 parameters? Hypertension, right on the screen, bradycardia, and usually respiratory depression, okay? So a lot of times in those severe head injuries, we said GCS of less than 8, then we have to intubate, excellent. So we are controlling their respiratory rate, so sometimes we lose that. But hypertension and bradycardia worsening, especially a widening pulse pressure, you are very close on the precipice of herniation, and that's a really bad thing, okay? So widening of pulse pressure, it can be very, very gradual, or it can be within like 5 minutes, and then they're dead, and that's very bad, okay? All right, so body temperature, we talked about thalamic injury and subthalamic injury and hypothalamic injury. So yes, the thalamus is going to, or the hypothalamus is really going to control our body temperature. Just remember that you might not realize it because even if it's, okay, it is July, right? So I had to wear a sweater when I was writing in today. It's July. It's going to be August next week, okay? It's been a weird year, I know. But even in July, if you're laying on the ground on a concrete and it's 80 degrees out, the concrete is colder than 80, so you can see hypothermia as a result of that. And you might not attribute it to a brain injury, but just kind of keep it in the back of your mind. All right, what do we do? Diagnostics for brain injuries. Everyone gets a CT scan, right? Has anybody delivered a patient to any area that did not have a CT scan available? Not that it was broken, because sometimes they do that, but no, never? Excellent, okay. So CT scan is, it's really nice. It's a very quick, very good exam that can tell you a lot about a lot of different things, but it is not any good for ligaments or cord, okay? So spinal cord injuries will get the CT Because head and spinal cord, if you have one, you automatically will assume another is present until radiographically proven otherwise. You have somebody that comes in or that you go and get who has a spinal cord injury, you assume he has a brain problem until the CT tells you otherwise. Same thing in reverse. They have a head injury, they stay collared until the CT scan shows that their C-spine is clear. We kind of don't care after that, but no. But every spinal cord injury will absolutely need an MRI. They'll need it quicker rather than later. And the reason they need that is because they watch the degree of swelling and they do serial exams. So like a Polaroid, if you think about it, and an HD movie. So it used to be knee jerk. Oh, we've got a spinal cord injury. Bam, get the surgeon in here now. We're going to fix him tomorrow morning at 0600. Sometimes now they will wait several days because when you go in and cause surgical trauma, surgery is trauma, just planned trauma, you can increase the swelling, and that on top of the initial swelling, which usually takes 2 to 3 days to peak, sometimes 3 to 4 days to peak, depending on the area of the spine. They may do one and then another one. If it looked very tight initially, they know what's going to happen, and they'll just watch the exam, clinical exam. Is your tingling higher? Do you now have only, I can't tell if it's sharp or dull, but I can feel you're poking something back there, and they'll watch clinical exams. Usually you will not see a second MRI until post-surgery. So sometimes it'll be a week or even a month later, and they'll go off of CT scans, and when they're looking at the CT scans, they're not looking at the cord because you can't, but you can see other associated structures and get an idea. And then those clinical exams are so important. Serial exams, it's not Captain Crunch. It's not Fruit Loops, okay? It's over and over and over again, and it's excruciatingly painful. Seriously, I'm going from here to there. I have to do an exam with you here, and I have to do an exam with you here, and it's like a 40-minute transport. Do it, okay? Really, really, really important. If they see anything different, they may decide to, oh, he's not doing well, we're going to bump him up and do him tomorrow instead of waiting until Thursday, okay? Okay, other diagnostics we might do, a cerebral angio. Really good. They can do so much stuff there, but really expensive. You're paying doctors, very well-trained doctors, and lots of them, and an entire team to do a cerebral angio versus a TCD. Super cheap. You're paying a tech to do that, and a neurologist will then interpret the results. What are they? A cerebral angio. So when I first started at Froedtert, and that was, it's going on 13 years ago now, we had one full-time neuro interventional guy. We now have 6. So I've not even been there 13 years, okay? And we have what's sextupled? I don't know. Our amount and then our range of, and we are one hospital in this area, okay? Aurora St. Luke's is another huge one, okay? They do just about as many things as Froedtert does, enormous. The amount and the ability of things without fully cracking someone's skull. We're not talking about cardiac, we're only talking about the brain right now. But the things that they can do now, they can correct vascular abnormalities, they can stent, they can plasty vessels in the brain, they can inject intra-arterial verapamil, okay, and resolve, almost completely resolve someone's vasospasm and cause them to go back to work, whereas if you had left it untreated or tried to do other things, like we're giving oral nimodipine, they would go to the group home because their cerebral vasospasm got so bad that they stroked out a part of their brain because of it. A vasospasm, just like you can have it if you're trying to put an IV in, and then they clamp down, and then you can't get that IV in, and then somebody else comes along and they poke, and they get it just fine, and they're like, you're dumb, and I'm great, right? No, that's because they were very likely in spasm, okay? Wait it out, by the way. Don't always yank the catheter out and say, oh, shoot, I missed it. Give it a second, and sometimes it'll loosen up on you. Really, seriously. Okay, that's enough about that. But that same thing happens in the brain, okay? Only in the brain, you're going to, constrict enough and then cause distal hypoxia, which will be a stroke, okay? Anyway, that's what cerebral angio, they can do all kinds of stuff of that. They can do so much stuff in the brain that we couldn't even 5 years ago. And they can go up with a clot, the Mercy retrieval gun. Anybody heard of this yet? It's fantastic. They go up, it's great. You go up there and it goes, and it goes, and it sucks that clot out. You don't have to, sometimes they do still put a stent, but it sucks it out. They withdraw the catheter, and suddenly within 2 hours, I'm now like, wow, I was over the time limit for TPA, so they've considered me a goner, but some blood was still getting past there and the damage isn't bad enough. We were able to get in there and vacuum out the clot quick. quick enough that now I'm fully back to normal, maybe a little speech problem or a little residual weakness in one hand or whatnot, okay? They have oh, it's just so cool the things they can do. But TCDs will give you, it's a Doppler, just like an ultrasound of the belly, the pregnancy, things like that. We want to do checking for blood and all kinds of other things. But the TCD is very cheap, but it's very limited. So you can only look at certain blood vessels, the ones that are close to the surface. So we can very easily view temporal, carotids, lower ones, and then you start to lose some of the vessels that you can evaluate with it. But you can tell based on the temporal different, they're distal by the time they get out to the surface, right? The important stuff is deeper and then it kind of branches off. But they can tell if they're starting to have any sort of vasospasm, and that might lead them, if his velocities or how much the blood vessel is doing this is getting worse on this cheap study, then they'll take them down right away and do the expensive stuff, okay? EEG, everybody knows what an EEG is, right? Nest forest of wires that's going on up there, and now it's so wonderful we have MRI compatible EEGs, so you don't have to rip that whole mess off their head. Go down, do the MRI, come back on and glue them back on again. It's awesome. You can just go down there. So there's just a funny little silly thing. So diffuse slowing, has anybody ever seen or heard that diagnosis on one of your patients? Perhaps on yourself? Like 90% of the population has diffuse slowing, but the neurologist gets to charge for it if he puts it in the chart and he did a read of the EKG or the EEG. I almost went forward without talking about the LP, the spinal tap, all that kind of good stuff. So everybody's seen, perhaps possibly somebody's experienced an LP. It's very easy to do, very bedside, very cheap. You do need a doctor, but very quick and easy, and you can get that good, perfect fluid that you can then send down to the lab and tell all sorts of stuff. Once you get CSF, they can do all kinds of stuff and tell what's going on with you a lot of the times. So we'll talk about radiology exams. Can anybody see anything wrong here? Yeah, but it's not, believe it or not. Yeah, something's wrong there, okay? So we're kind of like combining a little bit. But we've got serious cranial defects here, okay? So it's really not good. We're also missing some, incidentally, that's a great kind of patient. Why? You can always suction them. They can't bite down on their ET tube. Exactly. Good stuff. Sorry, I'm being cavalier. I didn't mean to be like that. So we'll talk about radiology, and then I have some x-rays and some CTs in here. Okay. Primary brain injury. You cannot do anything about their primary brain injury. That's what brought you to them, or that's what brought them to you, okay? Period. It's done. What we have a huge impact on and what we need to take seriously is our direct impact on their secondary injury, either to the brain or spinal cord, okay? Hypoxia and hypotension are the two most incredibly dangerous things for any brain and spinal cord injury. It's really that brain injury, really, really, really important, okay? We'll talk about that when we get to that side. So occur as a result of contact injuries. You've got your acceleration, your deceleration, so your rapid slowing down. So you've got, I was thrown off the bike, my car hit another car, I fell off the bunk bed and I was fine until I hit the floor, those kind of things, right? Okay. A contact injury is going to be a direct result of trauma to the head. Okay. Sudden changes in velocity, we talked about this, right? Why? Because it's sitting in a nice bath. It's not fixed. Excuse me, it moves back and forth, okay? Describe for me coup contra coup injury. Who knows what that is? Oh, you're demoing it. I love it. Very good. So coup means, it's French. It's funny. It's not coupe. It's always funny when somebody says coupe. And I'm really not a cultured person if you haven't picked that up by now, okay? But I really like it that I can say some French words like coup contra coup. Blow, counter blow, okay? So it is, you have a direct injury, and then the head will move back, and you'll have an injury to the opposite area of wherever was hit. Is it only this? No. It's this as well. This is more common. Yes, it's kind of funny. Kind of dizzy now. But your blow and then your counter blow as the brain bounces back, okay? And then if you are, say you're T-boned, bam, and then you snap like this, and then your head snaps the other way. So. All right, good stuff. So this is talking really about the rough portions of the skull. So on the outside, if we shaved our heads, okay, we would see a nice smooth surface. It might be bumpy, but it's not jagged. On the inside of your skull, it's very jagged, okay? Especially the base of your skull, okay? It's like little mountaintops, you know, little fingernails are scratching down there. So that's what it looks like on the inside. So that's why the blow, the coup, counter coup can be very, very damaging as well. But we just talked about what that is. Contra coup injury is on the opposite side. Secondary brain injuries. So we talked about this. You can have swelling, you can have edema, cerebral hyperemia. What is hyperemia? Take the word apart. Hi? Emia. Emia is blood, right? High blood, much blood, too much blood. So cerebral hyperemia, you've got too much blood up here. Is that possible? It is possible, okay? You do have normal, we all normally have intact autoregulatory mechanisms. At the point of one devastating brain injury or even a mild brain injury that either isn't maximally treated or just kind of progresses over time can result in loss of autoregulation. At that point, you have no ability to clamp down anymore to control your cerebral blood flow. And sometimes what can happen is if you're normally, let's say I'm going to drive home from here, I'm getting on the freeway and somebody cuts in front of me and I'm, why did you cut in front of me? You know, I'm getting very angry, right? My blood pressure's going up. I really don't get that bent out of shape in the car. It doesn't matter. I do at work, but not in the car. You know, oh, why don't I pass out? Why don't I die? Why do you think? My blood pressure goes up, okay? Why doesn't the blood pressure in my, we're going to call it blood pressure for right now, in my head go up? Or you're yelling at your kid, eat your peas! Why doesn't your head blood pressure, okay, it's your ICP, your intracranial pressure, why doesn't that go up to the point that you black out and die? In a normal person. Normal with big. You have normal autoregulatory mechanisms in place. So when the blood pressure goes up and maybe my cerebral blood volume goes up, so I have more blood up there, my brain is going to say, whoa, my ICP is going up. I don't like my ICP over XYZ number for a certain amount of time or I will pass out. That's a malignant issue there, okay? And then your carotids will start to clamp down, reduce blood flow up, and your jugulars will hopefully promote venous drainage out. You have just affected Monroe-Kelly. Incidentally pronounced Monroe-Keeley, but nobody ever said, I'd never say that. That was that British resident that I was telling you about who was so awesome. Like, you know, Kara, it is pronounced Monroe-Keeley doctrine. I said, okay, thank you, Dr. Beaumont, I appreciate it. So he's a good guy, you know what I mean? Incidentally, does anybody know what epistotonus is? I learned how to say this word as well. It's such a cool word. I know, it's not. It sounds like a religion. That's funny. Epistotonus is when you are seizing so hard, so you are maximally seizing, so much so that only your shoulders and your heels are touching the flat surface that you're laying on. So status epilepticus to the extreme, and you've all seen somebody seize. We've all seen that, right? But epistotonus, that's another word I learned from Dr. Beaumont. So you can quote him on that. It's really interesting. But I pronounced that incorrectly as well until he taught me. Now I say it correctly. But let's go back over here. So we've got our good autoregulatory mechanisms intact. So when I get all angry and my ICP starts to go up, my brain says, I don't want you to pass out and die, so let's slow down. It clamps down, doesn't let as much blood flow up, hopefully improves drainage out, and I get a little lightheaded maybe, so I'm going to stop freaking out, okay? And my ICP is going to stay in a normal range. That's autoregulation, okay? After a big bad injury or a lot of small injuries, you lose that ability or it's impaired somewhat. So what can happen is, with the more serious injuries, is that when your blood pressure goes up, you can't compensate anymore. Your ICP goes up as a direct result. So you can have someone, you know, you can watch as their blood pressure goes up, a normal blood pressure of, say, 130 systolic could cause their ICP to go to 40, which is really bad, okay, and stay there. So then we would put them on blood pressure medication like nicardipine to drop it down so that we can keep their ICP in a somewhat normal and just get them past that first critical 3 to 4 days of swelling, okay? All right, so that's cerebral hyperemia. This is what I was talking about also, the carbon dioxide retention. That's when your CO2 goes up. So when you don't breathe effectively and don't clear CO2, you have carbon dioxide retention. That's called hypercarbia, too much carbon dioxide in your blood. That will cause cerebral vasodilation, okay? We'll talk about how we fix that in a little bit. All right, scalp injuries, you guys have seen these. Everything above the neck is very vascular, so they get a lot of attention because they bleed a whole lot and people freak out, right? But they're easily fixed, right? Pretty much, maybe. You've got your contusions, remembering that if you have like the big goose egg there, the contusions, what you have on the outside can be present on the inside as well. You can bruise the outside just like you can bruise your brain, okay? Okay, so we'll talk a little bit about skull fractures. These are nice pictures of the different types. This is a really, really bad one. That's a really bad one. This one's kind of bad, kind of depending. You've got hemotympanum. It's kind of cool, right? But this one is really, really bad. And we'll talk about each of them. All right, linear skull fractures. Are these common? No. Do they happen? Yeah. What do we do for them? Absolutely nothing. We give them maybe some Tylenol 3 or some Percocets or something like that. Send them home and have somebody hang out with them, right? And tell them to come back if they need anything, okay? So that's pretty much it. There's nothing you can do for it. Sometimes they're an incidental finding. It means, oh, let's look at this brain. Oh, yeah, by the way, he's got a couple of linear skull fractures over his sagittal region, or parietal region. Okay, here's a nice picture of it. Okay. Depressed skull fractures. What do we do for these? Are they sad? Do we leave them alone? Do we give them some Zoloft? They're depressed. Okay, finally, what do we do for them? Maybe. So looking at what it is, and let me show you a picture. What do we need to do for that? Depressed means he might be sad, I don't know, but for sure his skull is depressed because it's below the surface of the skull. So he has to, each and every one of these, how small or how big, has to go to surgery, period. They typically do very, very well, okay? But why do they have to go to surgery? Exactly. So bone breaks nice and smooth and soft, right? No, it's jagged. It's got to be difficult. It's got to be temperamental. And it will shred the balloon, the dura, resulting in a CSF leak. Is that a good or a bad thing? That's a horrible thing. Because what do you really, it's super sky-high risk for? Infection, meningitis, bad, bad, bad stuff, right? So CSF is really high in what? Sugar. Really high in sugar. Did you know that? Whatever your blood glucose is, CSF has a sugar count. It's a measurable sugar count, okay? So it's really, really very attracted, bacteria are very attracted to CSF. So they will go on in and eat up all the good stuff and give you a raging infection in your brain, and that's really, really bad stuff, okay? So you're also causing damage to the parenchyma, or tissue of the brain, right? So you've got damage here. So they have to go in, they lift the pieces out. Sometimes they put a little plastic piece there, or sometimes they can put the bone itself back in, pin and screw it. They don't rot your skull, okay? It's not long enough for that. But sometimes they put hardware up, not usually. They'll come up with something else, okay? Or they have nice glues nowadays, okay? And they'll stay in the hospital for a couple of days, and then they'll go home, okay? So clinically, so you can see this one, he's got a bit of a goose egg, right? So he's got some blood accumulating under there. So when you're doing your checking your head to toe and all that kind of goodness, you're checking DCAP, BTLS, and all this wonderful kind of sort of stuff, and you start at the head and you go down to the feet, right? We start at the head and we're like, ooh, that's squishy. What do you do? Don't push too hard, but what do people actually do? What did I just feel? Do you feel that? Yeah, and then you get to the ED and they feel it, and the nurse says, oh, Dr. Jones, come over here, and he feels it, and then he gets his senior, and then he gets his chief, and then finally they call the neurosurgeon in. Meantime, we're all doing this, so what's going on underneath that? Yeah, bad stuff. So if you feel a truly mushy part, if you feel crepitus up here, there should never be crepitus up there. Okay, never ever. Then don't touch it anymore. Err on the side of caution. Don't block them in extra tight, okay, because now you're really increasing things there. Be careful and tell them that. Be very sure to tell them that and tell them don't to touch it either, okay? Oops, wait, let's go back here. So we talked about this. The skull is depressed. It's not sad. That means it's below the level. And then the dura may or may not be torn. Oftentimes is. Not always, but oftentimes is, and it depends. You can have soft tissue swelling, like the picture I showed you has the goose egg there, and bony step-offs, or crepitus deformities. These are all bad things. Open or closed is self-explanatory, right? If it's open, it's much worse than if it's closed. So a comminuted, this is just like any other comminuted fracture. It went all over them. There's multiple. This one is not too bad, okay? Whatever, but big fragments, not like tons of tiny little fragments. Okay, basilar skull fractures, all right? So this is the base of the skull. So this is the bottom of the skull. And it should be a nice round ring, just like your pelvic ring, okay? So I put a picture in here as well. So this is not a good problem. Can you see where the issues are? Is it there? Where? Everywhere, kind of. Particularly right here and right here. It should be a closed ring. So we've got a problem there and there. I know we don't need to read CTs in our job. I don't need to, but I like it. So I like when doctors tell me things that I can understand. It's like, oh. So if you don't want, you don't have to pay attention to this. But it should not be looking like that, okay? So this is huge, huge risk for a dural tear. I've yet to ever see a basilar skull fracture that did not have an associated dural tear and CSF leak. Why? Why would you be more susceptible at the bottom of your skull of tearing that balloon than if I got a depressed skull fracture up here? Gravity, yep. Pushing it down, more weight, more sloshing, more movement, that kind of sort of stuff, okay? So you're going to be really suspicious of, you know it. So otorrhea, rhinorrhea, right? People get really suspicious of otorrhea because we shouldn't have fluid coming out of our ears, right? But in January, you walk into any emergency department and there's just as many staff going as there are patients, right? It's January. We all have colds and we're grossed out and stuff like that. If history mechanism is telling you this might be any question that it might be a CSF leak, what do you think you could do? Can you do something in your rig? The halo test. Oh, love it. So the halo test is perfect. So you put a drop of that fluid on something white. Linen is better. Not the pillowcase with all the flowers and junk, but a plain white pillowcase, but a 2x2 will do, okay? Something that's absorbent. And after it dries pretty quickly, then you see that golden halo, right? So it does show up. Sometimes it's very faint. What do you do with that once it dries and you see it? Great. I was right. Throw it away. Save it for the neurosurgeon. He's going to want to see it. We want to mess with that as little as possible. If you can't tell, because sometimes it's very faint and you're not sure, and it looks like snot coming out, but it doesn't make sense. It's July. Why would they have a runny nose? What else can you do? Bedside test, point of care test. It does require a little bit of a machine. A blood sugar, fantastic. Why a blood sugar? Snot does not have a measurable glucose. CSF does. Oh, good. That makes me happy. A light bulb went on. Okay, maybe if I only do that once, then that makes me happy. It affects all the rest of the blathering I've been doing. Okay, great. And then tell them, and then they'll know too. So again, that parietal region. Okay, remember, oh yeah, when they have a basilar skull fracture, what do they always get that you almost never see in the field because there's not time for it to happen? Raccoon eyes means, right, the periorbital ecchymosis and the, what did you say? Battle sign, mastoid ecchymosis, yes, but you never see that right away, do you? No, so it's like hard to do the same job with less resources, right? So that's why you're the bomb. Okay, great. Oh, and I answered this earlier. I didn't mean to, but what else is very, very common when you're hit upside the head? When you're hit alongside the head, so it's usually a blunt trauma. The ear trauma, I was talking about it earlier, a specific type of bleed. So mechanism-wise, you're going to be watching when you have parietal or even temporal. It's a bleed within the brain. It's a epidural bleed because of that middle meningeal artery. 93% of epidurals come from a hit here, okay? So almost always a traumatic event. We talked about that. Facial fractures. People that usually have facial fractures oftentimes will have brain injuries as well, okay? You can punch somebody around the face, the nose, the whatever, but it's really hard to break a bone up here, anywhere. I mean, really anywhere if you're not 85 and osteoporotic and whatnot, but it really is kind of hard, so watch for other injuries. If you have any suspicion, possibly, if they have one black eye, not two, but if you have any suspicion that they might have any injuries here, I just hit my own nose, that might also lead to a basilar skull fracture, what are you never going to do? Yes, don't put anything longer than a nasal cannula in that nose, okay? And I don't think I included it here, but I have a fantastic, blessedly old x-ray of a skull with a, I have it actually on my thing, I can show you after if you want, of a NG coiled up in the brain. Bad. You do not want to be the person doing that. Upper right, yes, this is actually like the patient's left, right? So that's it. So what do they do for a contusion? Depending. If it's a big one, they'll go in with an ice cream scoop and scoop it out. If it's a little one, they'll wait a little while. And the terminology for contusion is they watch it blossom. It's a very pretty word for a very ugly thing. And because there's swelling associated, right? If it's small enough, then the patient is maybe going to be okay and can deal with the other stuff. But they'll just go in with the ice cream scoop if they need to and get rid of it. And there goes your second and third grade memories. And then, you know, I'm just joking about that, okay? But, and then the skull closes back up and they can do just fine. They could do just fine. Where is this in the brain? So what is this patient going to be clinically? For a while, he's going to be inappropriate. He's going to have no judgment. He's going to be totally disinhibited, okay? And often hypersexual. Not like trying to be, you can't hold him responsible for that stuff. They're very difficult patients to care for. Lacerations that penetrate the skull can cause tearing to the actual surface, the parenchyma, cortical surface of the brain. We talked about epidural hematomas kind of a good bit. It's the epidural hematoma. Epidural, where is it? Above the dura. So it's outside the balloon, inside the brain, right? It's between the dura and the skull. Is that a venous or an arterial bleed? Arterial, okay? These are very, very serious things if they're big, okay? Very serious, because you will either die or you will be just fine. The only thing you need is a neurosurgeon so they can go and fix you and then you're fine and you go home. I have some pictures here. So epidural. Do you see how pretty it is? So we've got, ouch, you know, that's skull, that's blood, that's bad stuff. But do you see how it's very clearly defined? Why? Because it's outside the balloon, okay? So this is actually a further back, okay? They usually wind up being like here. So this would have been a little further down, very likely, the middle meningeal artery, not right smack in the meaty middle of it, right? So the classic presentation, you as EMS are going to be the #1 people that could save somebody's, you know, really like true, I know it's every day you could save somebody's life and junk, but like seriously, epidural hematoma, classic presentation. An initial loss of consciousness, followed by a brief lucid period, and then a rapid neurological decline. Those are big, fancy, stupid words. What does that mean? I crashed my bike, I call 911. By the time you get there, I'm out. What's going on? This is an arterial bleed. So you have an opening in the vessel, causing a big, huge, sudden jump in ICP. So my brain says, whoa, let's turn the lights out for a little bit. My ICP went up too high, I lost consciousness. And then gradually, the pressure of the brain kind of tamponades off that bleeder if possible. Not all of them present like this, okay? But this pressure will overcome this pressure and it'll hold on for a minute, thereby stabilizing, and autoregulation is still sort of intact, so it'll sort of stabilize your ICP and then you can come to again, right? But it's an arterial tear. It's under a lot of pressure or a little pressure? A lot of pressure. So eventually it's going to overcome, and then you go down again, okay? And a lucid period or a with it period does not mean you're alert and oriented ×4. It means you're awake. But not everybody regains consciousness again. It depends on how big the initial tear is, how big the initial bleed is. And again, small ones, they'll medically manage, watch them. They'll watch them in the hospital though, okay? And then they may go home. Big ones go to the ED or go to the OR, and usually they're home before the small ones are because they can just fix it right away, okay? But it's not worth opening someone's brain. You don't want to do that ever if you don't have to, okay? All right, brainstem herniation, we talked about that a little bit. Expanding brain herniation is things are getting squished, and most commonly, well, there's two different, we're not even going to talk about that, but the brain gets squeezed enough that sometimes it pushes down through the big hole and pushes down, and then you have no blood flow to the brain. Okay, so it goes down through to where the spinal cord is. That's, we're just going to leave it at that. That's bad. Okay, you are brain dead. Contrary to what the news tells you, okay, you are dead when you are brain dead. You're not, oh, I'm brain dead and now he's back at work. Those crummy doctors. No, that's not it. You do not ever, ever, ever come back from brain dead, right? Everybody knows that? Great. Okay, okay. Subdural hematoma results from an injury that is subdural. Where is it? below the dura. So subdural, below the dura, so it's between the dura and the brain, the balloon and the brain. The balloon and the brain. Here's your subdural. Do you see how different it looks? It's infiltrating the brain tissue. It's not pretty. It's not neat. None of it's pretty, right? But it's infiltrating the brain tissue, okay? It's bad. It looks kind of really bad, okay? Incidentally, let's go real back to right here. What is this? That's your lateral ventricle. Where's the other one? You should have one or two. It's shifted. How do you know it's shifted?
You can kind of see the outline of it.
A little bit right there, right? Incidentally, at this level, you can tell by how much is showing, how high up. These both should be much bigger, okay? But you can watch the midline of the brain, okay? And on the CT scans, they always draw a little line and sometimes they make a little arrow or something. I couldn't get it to come in on this one either. But, you know, here's your ventricle. This is pushing all this over, okay? If we look at the subdural, so we're a little off right smack in the middle, kind of looking where everything is. But can you see the little bit? The back horn of one, okay? And we've got another one that should be, but again, it's pushing things over, okay? Okay. Did we talk about? Yep, we did. Okay. A concussion is a diffuse injury. Remember, a concussion is a diagnosis of exclusion. There's nothing else wrong with you. We can't prove it radiologically, so I keep standing right in the middle of you there, sorry. It's, again, the classic definition does or it can or cannot include a loss of consciousness, but oftentimes it's a loss of consciousness, and then when you regain consciousness, it is with usually no more than 2 focal neurologic deficits. So what does that mean? Having speech problems or a little numbness in my left hand, or I'm having double vision, you know what I mean? And again, you cannot prove this. History makes it make sense. I fell off the bunk bed. Either I was or I wasn't, having a loss of consciousness, but now I'm having troubles doing simple math, or if I'm like a 5th grader, I can't, I got a bad headache, and, so it's a concussion. You can't do anything for them except supportive care, and they kind of get over it eventually. Anybody had a concussion? Yeah, usually a lot more than 2 people, so 3 maybe. Okay, me too. And they're additive as well, right? They're additive as well, right? Thank goodness the NFL, everybody's watching all that business. So too many, and you're done for the amount of time, and then you're done for the year, and all those lawsuits going on, my goodness. Okay, any loss of consciousness, remember that does not always have to happen. Amnesia, this can be event amnesia, retrograde amnesia. It's not, I forgot what my name is, and I don't know where I go to school. It's not that kind of amnesia, but it's more related around the event. Any alteration in mental status at the time of the injury. We talk about, these focal neurologic deficits when you're not unconscious for longer than 30 minutes. So I have to tell you, a loss of consciousness for more than 30 minutes, you are really bad off, okay? You are not going to be having just a concussion, period. You're out for 30 minutes, you either did some drugs, that's like a totally reason, that doesn't have anything to do with the brain itself, But more than 5 minutes, the neurosurgeon gets very concerned, okay? Being truly out for more than 5 minutes. And then they may have the GCS score of 13 to 15. So I will briefly talk about this post-concussive syndrome. I just wanted to mention this because you get called to the home of, George Smith, and he's 24 years old. I got this splitting headache, man. I couldn't even drive myself to the ED, and it hurt so bad. And last time I went in there, they gave me this stuff. It started with a D, and they put it in my IV, and it really helped, and I need it. Can you give me some of that? What are you thinking? Oh, yes, you are. You know it. However, you are a good healthcare provider. You are a good person, and you do a full history, and you find out that he was in a bad car crash, 6 weeks ago, 2 months ago, okay, 6 to 8 weeks ago. Post-concussive syndrome is a true, real diagnostic diagnosis, okay? And it's totally nonspecific. So check history, have him go to the ED and get histolotted that he wants, or his morphine and his IV Benadryl that he wants, not the pill form, but all that kind of good stuff. But no, absolutely, don't dismiss them. It really is truly, absolutely, real, okay? So honestly. And it can persist for up to 6 months. Remember, the more often you have them, who has them all the time? Athletes, young, healthy males, right? Possibly over and over and over again, okay? So they're not just drug seeking. We talked about DAI a lot. Oh, back then, I couldn't get that doggone animation to work. I'm really mad about it. Occurs over a wide area. There's absolutely nothing that they can do for these. Most common in rapid deceleration. Fell off the motorcycle, was in the crash, you know what I mean, had a seatbelt on, but still my head snapped forward, those kind of sort of things. These statistics are slightly out of date. DAI accounting frequently, almost, not all the time, but almost all the time, the DAI is associated with another bleed, most frequently a subdural, traumatic subdural, okay? So DAI is never a diagnosis ever that is made in the ED or in the field, ever, because it needs an MRI to diagnose. It does not show up on CT. You have to have an MRI, and so they usually suspicious later on. They're like, well, his brain has, you know, healed, his subdural's healed, what's going on? He won't wake up, we can't wean him from the vent. Let's go down and do an MRI. Ooh, he's got severe DAI. So we will supportively care for him. He will get a trach and a peg and go off and live for a long time. All this heals. Wear your helmets if you're doing anything at all, okay? So physiology of ICP, we've talked about this a little bit. So 0 is really kind of not like your CVP is supposed to be 0 to 2. Nobody has a CVP of 0. Nobody has an ICP of 0, but it's possible. So usually less than 15, less than 20. Does your ICP ever go up above 20? Yes. Does it go above 25? Yes. Does it go above 30? Not usually, okay? Really not usually. So when does it go up? When I was talking like, hey, eat your peas, or why'd you cut me off, you little razza-frazza, you know, all that kind of sort of stuff. We compensate. We will do other things to reduce our ICP, and eventually you'll either pass out and stop whatever you were doing, or you will, or you won't, and you'll have this big bad brain injury. So no. But we talked about CSF. Approximately, around the clock, you produce approximately 20 to 22 cc's of CSF an hour, continuously, forever. We have drugs that can try to reduce the amount if you need to. If you have something called normal pressure hydrocephalus, which I was very happy to see was actually in here. But either way, CSF, if you are having malignant ICP issues, we might temporarily do what I was talking about, put a straw, an EVD. So that's just a straw that externalizes, and we will do the absorbing until the blood resolves or all the swelling resolves, and eventually we will cap that off, and they put a couple stitches in your scalp, and you're just fine and dandy, okay? Obstruction to venous outflow. So way back when I was showing you that picture of the skull with the blood vessels that were coming, so venous outflow occurs primarily with those IJs. So that's why brain doctors, neurology or neurosurge, does not like to clog up those jugulars. So try hard not to, you know, if any suspicion. EJ is a little bit different, but even there we really kind of shouldn't do that. Okay. As the ICP increases, the venous pressure will increase a little bit, so I put this little comment here of if autoregulation is intact, okay? So this is, to a certain extent, possible, to a certain extent, not possible, okay? If you have a person with a really devastating closed head injury, okay, their ICP is going to go up to 20, 30, 40. You can't, at a certain point, get your blood pressure high enough. You can't get your cerebral blood volume high enough. Eventually, that's when you start to have cerebral death, okay? And eventually, you can have, like, full-on herniation, all right? So it's kind of like a slide, a spectrum. So increase in ICP can result from changes in the CSF, okay, if they're making too much CSF, or if they're not reabsorbing at the same rate they used to be, okay, or if they're not, I don't know what I was going to say with that, but edema related to a lesion, a bleed, anything, any expanding masses or lesions that are in there, changes in vessel size, okay, this all kind of makes sense. If you alter one part, you're going to alter, you're going to see changes in mental status, possibly resulting in up until death. Okay, that's Monroe-Kelly. Cerebral blood flow, the brain, we talked about that. Brain uses a whole lot of blood, and blood flow, cerebral blood flow, CBF, remains usually constant between 60 and 150. It's a very wide variance. You're not caring about the CBF. What you're caring about is the CPP, which we'll talk about. CPP stands for cerebral perfusion pressure. Incidentally, cardiologists will tell you it's coronary perfusion pressure, totally different formula, okay? We're talking about the brain. It's your MAP minus your ICP, A normal map, where are you happy with a map? Map of 60, I'm very happy, right? Map of 60, and a normal ICP I said was 15. Let's make it real easy. We're going to say it's 10. My ICP is 10. My map is 60. What's my CPP? 50. So is that a good CPP? No, that's a bad, really bad CPP, okay? But that's normal, so why aren't I dead? Multiple studies have shown that a CPP of less than 50 millimeters mercury for 5 minutes results in a 50% greater mortality, okay? 5 minutes is nothing. I know it takes forever in a class like this, but it's really, really nothing. So why aren't we all dead? Because we have a wonderful thing called auto-regulation, okay? So we will auto-regulate. We will clamp down on blood going in. We will open up, hopefully, and help blood go down. And then we will just turn the lights out so that you are reducing the amount of demand on your brain, okay? You go night-night, then you don't have to, yell at the guy in front of you in traffic and whatnot. Remembering these mechanisms are often lost after head trauma, 50 and 70. So the bare minimum is 60. Much literature in the last 10 years really points to greater than 70. So if a CPP of greater than 70 is good, is a CPP of greater than 90 even better? No, it's not. So more is not always better, okay? So it's not that much better because you will get, that's hyperemia. That's too much blood up there. There's not enough room, so you don't want a super high blood pressure. A map of 60 is good. A map of 110, that's kind of not good, right? So really, ideally, between 60 and 70, between 60 and 80 is kind of okay. Greater than 70 is really where the literature is pointing nowadays. We talked about this. Early hypotension is really bad. Bad morbidity, bad for mortality, hypotension, hypoxia. Truly devastating. And they don't happen in your rig. They're devastating way later on down the line when that person goes either home or to a skilled nursing facility. So any change causing an increase in the volume in the skull will cause an increase in ICP unless there is a corresponding change in another volume in the skull. So what's that doctrine? Something Kelly. It's Monroe-Kelly. Yeah, very important. You have 3 things that exist in here. You have brain. What do you think another one is? Blood. CSF, okay? Brain, blood, and CSF. So if you have too much blood up there, something's got to give. Otherwise, you're going to have the lights go out. If you have too much CSF, that's hydrocephalus, something's got to give. Otherwise, the lights go out. Can you ever get more brains? I wish, but no, I can't. But so what are they talking about? Like if you have an increase in brain volume, what does that mean? Swelling, right? After either because of a lesion or a bleed or something else like that. So increased ICP, the textbook definition would be sustained elevation above 20, okay? Sustained elevation is a key word there. Compensatory mechanisms, what does our body automatically do? It shunts CSF down, okay? Down, away, out of the brain, and it will increase how fast we reabsorb it. All these things are automatic. This is a slow process. It's going to happen over days, okay? Hours to days. So this is not going to be a quick fix. The quick fix is your body turning the lights out, drastically reducing blood volume up there, and then you go unconscious. Or getting a neurosurgeon to drill a hole in your head, and then you have a nice straw to suck all the extra CSF out. Cushing's triad, we talked about that a lot, but it was in here again. So remember, it's hypertension, bradycardia, and often respiratory depression. But a lot of times you don't see respiratory depression, right? Because with a bad brain injury, why don't we see respiratory depression? Because they're tubed and we're controlling their airway. So we lose that criteria. So watch for that widening pulse pressure, and the blood pressure goes up and the heart rate goes down, okay? Herniation, we did talk about this. A portion of the brain can be displaced here, there, or anywhere. Remembering that your numbers don't always go up. If you have a brain stem issue and you have swelling in the brain stem, you can have a normal ICP and have the brain herniate downward and become brain dead with a normal ICP until you're brain dead, and then it becomes 0. We're not going to go heavy into uncal herniation versus herniation downward out of the foramen magnum. It's just brain herniation is what brain herniation is, okay? Either above or below the tentorium. Another type, we talked about that. Okay, so here's a nice picture. It's a good picture. Can you see there? What do we got? This is good stuff, right? This is why we do what we do. Where do you see the open skull? Put my finger up or down? Left. Yeah, that's bad, right? So that looks like more than just scalp to me. That looks like skull as well. Is that all we got going on? A burn? Yeah, he's got some stuff going on here and some dirt and stuff. We want to wipe that off, right? That's gross. That's snot. Could be a motorcycle accident with no helmet. Yeah. No, that's brains. Have you ever seen brains? Brains are extremely unimpressive. They look like overcooked pasta. They really do. So you want to wipe that off? Oh my God, don't touch it, okay? Don't touch it. Don't wipe it away. More will take its place, okay? Let the neurosurgeon come and wipe it away, okay? Really, your brain is under a lot of pressure. What happens when we open the cranial vault? It wants to expand out like that can of chip can and all the snakes kind of come flying out of it, right? Like that funny party joke. That's what happens, okay? Do not disturb it at all, okay? You would not block this gentleman. You would drug him if he's not already out. You would not put anything in his head if you can help it, okay? Or make it very loose, okay? I know protocols and whatnot, okay? But we would put a sterile, dry something over that and then leave it alone completely. We are not going to try to wash that, make it pretty, nothing until the neurosurgeon, he is going where? To the OR if he makes it. What is the question up on top? What's the answer? It's actually low. Why? So your patients with facial fractures often don't have ICP problems. Why? Okay, so it can be a good and a bad thing. So he's not at risk for super high ICP. He'll probably wind up with a bolt at least, if not an EVD. But why? What is he really at high risk for? Infection. We definitely have CSF leakage. We definitely have all kinds of bad stuff there. Okay, so that's obviously an indication for an ICP monitor, right? If he makes it, he's going to get a bolt, which literally is a big giant screw drilled. They sit there and drill at the head of the bed. Have you seen him put one of these in? It's fantastic. They sit there with a hand drill and drill into the skull, and I've seen it shoot back and hit the ceiling. They can be under such high pressure, but they are maximally garbed. It splashes on their goggles, then you have to give them a new mask and whatnot. So, but you can really, really, really drastically, very drastically improve someone's exam by putting in an EVD is a straw. The bolt is just to monitor. It doesn't go, so the straw or the ventriculostomy or external ventricular drain, those all mean the same thing. Those go into that ventricle we were talking about. It's a straw. The bolt, which I think no, he didn't have one. I think I have a picture later on of a bolt. That is literally a big fiber optic catheter put through a screw in the brain, and it sits in the parenchyma, the tissue. It does not go into any fluid. It does not do anything. It just watches, okay? It's like an EKG monitor. It just watches. It doesn't do anything at all, versus your defibrillator is going to do something. Okay, so a positive CT is another reason to ICP monitor. Is that a happy thing? Is that a smiley face, a positive CT? No, positive CTs are bad. We want negative CTs. We want negative for bleed, negative for lesion, negative for everything. Any of these reasons we might put more in. We might put in a bolt or an EVD, okay? Shift, big time. So how do we do it? Non-invasive is watching exams. So I put this here like the cereal or cereal. So no, it's not Captain Crunch, right? It's over and over and over and over and over again. Okay. Invasive methods, that's going to be your bolt or your EVD. So your IVC, intraventricular cannula, it's more frequently called a ventriculostomy or an EVD, and that's your bolt, and you're bolting the parenchyma. It really is, it's a screw. It's really, it looks like what you would have in your toolbox. Obviously infection can be a problem. You can have a bleed if somebody puts it in wrong. Air leakage. So a pneumocephaly is a bad thing. How do you fix a pneumocephaly? Any idea? So that's air in the brain. Nope, because you can't sometimes. Most times you can't because they're still sick. So this therapy that we do is kind of like, you know, like inhaled albuterol for treating a high potassium. It's to apply high flow oxygen, and that gradually helps it reabsorb. The short real answer is nothing. You have to let it resolve over time. So what does it do? It's very common after surgeries, especially emergent surgeries. Not so common in EVD and bolt placement. I've actually never seen that. But in having after surgery. They get these sometimes, especially if they've removed a space-occupying lesion, and before it fills up with fluid, you know, you can get some air in there and whatnot, but you just wait. And they have excruciating headaches. It's really, really bad headaches. But we would do maximal high flow oxygen for 2 hours, off for 2 hours. On for 2 hours, off for 2 hours, around the clock. What's another complication here? Over drainage of CSF. So this is always our fault. We drain too much CSF from them, okay? Either we suctioned them, so we caused them to cough like crazy and forgot to clamp the catheter before we did that, so they go, you know, and the CSF is shooting out of their head into the catheter, or we placed the buretrol too low, or we weren't watching it carefully and we raised their head without raising the level of the buretrol. So over drainage is like always our fault, okay? As soon as I say always, something else is going to come up that is not, but really it's always our fault. Okay. If the catheter occludes, obviously, if you're doing an inappropriate, I don't know really what they mean by inappropriate therapy. So complication of ICP monitoring, all I can think of is inappropriate drug coverage, because they do need to be on a prophylactic antibiotic. They don't need vancomycin, but they need like some Zosyn, okay? Not Zosyn, I'm sorry, Ancef, not Zosyn, that's pneumonia, sorry. Problems, so it can, benefits, so good and the bad. It can assist, you can put in an elective EVD to see if someone's normal pressure hydrocephalus gets better, and then they'll be a candidate for a shunt, and then they'll go off and live their lives, okay? And that's good. So you see somebody with the gait like this? Do you ever see this, walking in the mall? You ever see that? What is that? They need a shunt. They have normal pressure hydrocephalus or Parkinson's. So watch that. You can watch for that in your family members and get them to a neurologist right away for a diagnosis, okay? So what else? This big sad face. Problems, we can provide an additional assessment when we're suspecting brain death. So if someone's brain dead, again, there's multiple other things nowadays that we can do. We do not put in an EVD for diagnostic criteria. However, a lot of times they already have one in. So when you have a flat ICP waveform and a reading of 0, sorry, it's like a flat EKG. That's true. You know, it's like a flat art line. That's true. If you have an ICP of 120, which I've seen, and it's also flat, that's just as bad, okay? All right, cost, risk of infection, and hemorrhage, those are all bad things. Here we go. Here's a picture of a nice sick patient with a bolt. And this is a horrible dressing. Bad. Never use this type of dressing ever. It should never look like this. This is terrible. Huge risk of infection right here. This is not even close to sterile. That's paper tape. It's covering everything. Oh my goodness. You can't assess the site. So here's a picture of what not to do dressing-wise, but that's exactly what it looks like. And this is terrible placement. So this is kind of a picture of what not to do, but it was all I could find. Kind of looping it around, and it weighs like, you know, like a pound. This is a long catheter that kind of plugs into itself. This is a fiber optic catheter. It does not drain anything. You have to clip it to their cervical collar. You have to clip it on something that's going to, or if they're wearing an ETAD or a, oh my God, comfit, sorry. You've got the comfit on, clip it to that. If you're transporting them, they'll have some sort, you have a bolt in, you absolutely have an ET tube in, so you'll have something to secure it to. But what happens is, you turn them over, that thing slides off, and then the fiber optic catheter is now out. The bolt will stay there, but that catheter will go whoops, and it's out. So that's really bad. There are 3 slides on here on how to, the skill drill. So there are 1,000 different models of this. I'm not going over these slides because this may or may not be what you have to work with, and every hospital, like at Froedtert, we use one. At Community Memorial, which is a Froedtert hospital, we use a different one. At Aurora, we get patients in from Aurora, and they have different ones in. And I've seen a 4th type at the Wheaton system as well when I've done stuff over there. So don't worry about what this specifically thinks. The most important thing is to remember you need to zero this just like an arterial invasive line, and make sure you have your volume or your waveform correct. Okay, aseptic technique is beyond critically important. Never touch this thing. Don't mess with it. Don't ever change the bag, ever, ever, ever in transit. We wait to change the bag until the last possible minute when it's like over 2/3 full, at 3/4 full, because we can never be as clean as we need to be. You just really need to be careful, and you are absolutely going to be inducing bacteria directly into their brain and almost giving them a death sentence. So strict aseptic technique. This is not one of those times where we're just like, oh, I'll just hurry up and slap it on and not worry about letting it dry. Leave it alone, but if you have to mess with it, it needs to be strict aseptic technique, okay? Leveling in zero we talked about. No hyperextension or flexion, no rotation of the neck. When you have a bad ICP issue, you want to promote venous drainage. Neutral head alignment is where it's at, okay? Raise their head if you can bend them. If they're in spinal precautions, every bed, every cart now, I know you guys, it doesn't in the rig, but try to, as much as possible, get them, tilt the board that they're on then with some towels or blankets underneath it, and gravity helps a huge amount. Does the collar need to be strangulating them? You're obstructing venous outflow. If they're out of it, loosen the collar. Don't take it off. I'm not saying that. We can't clear them, but loosen it a little bit, okay? Promote venous drainage any way that you can. No Trendelenburg. Trendelenburg, honestly, has gone out of vogue. It goes in and out of vogue every 5 minutes, so no, we're not going to do that, right? All right. Precautions for the ICP monitoring. High ICP alarm. This is an important one. Avoid getting the filter wet. So that fancy pants, they don't have a good shot in here of the buretrol. Here's where it kind of sort of is. This is the measuring zero line. But there's, in all the chambers, they have like a store. It's called a buretrol. It's a long storage chamber. You know what I mean? If you lay that flat, there's a little filter on top. I don't know why they haven't come up with something to fix this. But if it gets wet, it is useless and it will not drain through anymore. I'm not a mechanical person. I don't know why that is. But then the whole system has to be changed. So is that good? No, that's really bad, okay? That's not a bag change. That's the whole EVD system. You have to change it at the connection point at the brain. That's really bad, okay? Big chance of bacteria. So you want to open that system like never, okay? Only a little bit of CSF at one time. So if you're going to suction them, if they're coughing, clamp the drain so that they can't spurt out a ton of CSF. First line management, we talk about making the patient comfortable. Effective handling of the ABCs of trauma management is total common sense. You guys know all of that. Second line management, we're going to induce cerebral vasoconstriction. We have to be very, 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 very careful, okay? So very briefly, the mannitol discussion, administration of an osmotic diuretic. That really now, that's mannitol. Anybody ever given it? How do we give mannitol?
As fast as possible.
You got it.
Sirens and hope she isn't back.
You know it. And it comes in bottles of 50 milliliters. That's 12.5 grams. That's like standard everywhere, right? So are you going to give somebody 50 milliliters? They're really crumping down in front of you? You might give 4, 6, 8 bottles of that. I mean, you got to follow your doctor's orders and stuff like that. But it is not. I received a patient like 3 weeks ago from an outside hospital who had a mannitol drip. No, okay? We do not. This is not mannitol drips. No, that's way out of vogue. Never drip it. If you're going to give it, they need it. And you should have the imprint of the syringe on the heel of your hand from pushing so hard, okay? How does it work? You're giving it because very likely you've now got a fixed and blown pupil, right? So you've got pressure on the optic nerve up there, okay? Bam, let's give them 50 of mannitol. Let's give them 4 bottles of mannitol. So we will, what is an osmotic diuretic? It's a big fat molecule that we're introducing into the vessel, right? The vascular space. And water follows what gradient? Uphill or downhill? Downhill. Water flows downhill, right? So we have now made the vascular space, okay? We've put this huge, gigantic, not a protein, molecule into the vascular space, and there's high pressure up here and low pressure in the blood. So the water wants to go from the brain tissue, the free water, the extra water that's around there, and it goes out of the tissue into, I'm bringing this down to a level that's easy to talk, you know what I mean? Anybody got their PhD in pharmacokinetics yet? Because I'm taking some liberties here, and I know I'm taking them, but I'm doing it on purpose as my disclaimer, okay? And then it goes in, all that free water goes into the vascular space, and then what? It goes through the kidneys, and then you pee it out, right? It's an osmotic diuretic. It's fantastic, okay? So it will draw that water out of the brain into the blood vasculature, and then you will pee it out. So now you have affected Monroe-Kelly. You have reduced the amount of brain, kind of, sort of, in there, so your ICP goes down, right? So what happens, and you give them 4 bottles of mannitol, they're going to pee out 2, 3, 4, 5, 6 liters of fluid, okay? It's going to work if you give it, and the body's able to respond to it. So what happens to your blood pressure when you pee out a gallon of fluid? So what do you do for a low blood pressure? So does the fluid stop here? So what happens to your ICP? So what might you have to give again? Really? And what happens to the fluid? Gosh, right? So yes, we do that in medicine sometimes, but it will affect, you really want to keep that ICP down, so don't be afraid to slam mannitol. Incidentally, if you have a nice IJ introducer up here and a 14 gauge in the AC, where do you want to give the mannitol? Why do you want to give a central rather than peripheral? If it's a good peripheral, okay? Why do you want to give mannitol peripherally rather than centrally? Because the catheter size is this small. That's a lot of volume, and you'll get it to them faster, you know what I mean? So if someone's dead, obviously you're not pushing mannitol anyway, so bear with me on the train that I'm going here. But it's a lot easier to push mannitol through a peripheral, never through a PICC line. If that's all you got to use it. Or a central line if you have to, you know what I mean? But if you have the choice, if you have a good peripheral and subclavian or an IJ, well, you don't want to be disturbing this, right? If you've got head stuff going on either. So, okay, sorry. All right, hyperventilation, briefly to talk about. Hyperventilation will work, but it is absolutely dangerous. Hyperventilation is something, when I started in the NI in 2002, we used to hyperventilate as a first-line therapy. That was only 12 years ago, right? So we would hyperventilate. Initially, when you have ICP going up, you bag them really fast. Why? Why do we do that? What's the patho there? Why do we bag them very fast? Let's go and kind of ring through. So when I hyperventilate, what's happening to a number on my ABG? Something's happened to my carbon dioxide. So I talked about spinal cord injury, who was not breathing effectively, wasn't breathing deep, and his carbon dioxide went what? Up. Hypercarbia is bad. Hypocarbia is bad too, but yes. So you're blowing it off. So your CO2, you're blowing it all off. Your CO2 is going to go down, right? PCO2 of 30, 25, 22, okay? It will go down. What happens? It is a direct effect when you have your PCO2 go down, when you have hypocarbia to a certain extent. The direct effect is cerebral vasoconstriction, okay? So you are altering Monroe-Kelly, right? You are now reducing the amount of blood. We talked about mannitol will alter Monroe-Kelly by reducing the amount of brain, right? Hyperventilation will reduce the amount of blood, right? So that's good, right? Our ICP will go down. Is that right? That's correct. ICP will go down. What is the bad flip side to having reduced blood in the brain? Drastically reduced, acutely reduced blood flow to the brain is what? That's the definition of a stroke. The reason we do not do it, and it needs to be, we're not talking mild hyperventilation, but that acute where we're bagging them like crazy, you will fix your number. It will get better, but they will suffer a stroke. That's why we don't do it first line anymore, okay? So do it if you have to, but don't do it if you don't have to. Try to use other things, all right? Because we are having all these patients, and that's why evidence proves it. So, and again, that's not mild hyperventilation, and if it's life or death, you do what you got to do, right? Okay. So also the flip side of hyperventilation, the minute you stop doing it, you get rebound vasoedema, okay, or vasodilation. So it rebounds, and your number can actually be worse. Spinal cord injuries, I know we kind of talked about this to death, but we've got rapid deceleration, can be a result of rapid acceleration. These flexion extension injuries, so remember, if you get in a head-on crash, where does your head go first? Hyperflexion, and then it goes hyperextension. People get that mixed up, so everybody hyperflex your neck and hyperextend. Good, hyperflex, hyperextend. Okay, great. Usually this is a result of an injury in the cervical region. That makes sense. It can result in ligamental injuries and possibly spinal cord injury. We are a species of like lollipops. We have like, well, not me, but some people are. Little stick bodies and big giant heads, you know what I mean? It's like, geez, how do we survive? We got strong necks. Vertical compression is your axial load injury. How do you damage that? How do you do this to yourself? Almost exclusively? It's July. What are a lot of people doing outside? Diving and not checking the depth, right? So you go in and boom, but yes, it can happen the other way. So especially in those certain type of patient, axial loading can occur the other way. You're just a little bit lower down. You know, you think about those calcaneal fractures, but you also get the lumbar injuries as well. But usually it's a diving injury. So talking about falls, this kind of makes sense. We just talked about that and the jumping and burning building and things like that, you know. All right, rotation with flexion. This can occur, not usually excessively common. Stable or unstable fractures deserves a chat about. Stable is not, are they stable or unstable? Stable has to do with the vertebral body stability and whether or not it will result in impingement upon the cord through the process of normal healing or through the process of normal physiologic loading as we're walking around afterwards, okay? So if I break a bone in my back and it's a simple, you know, linear fracture, then I might be just fine, and that's how I just walk around with a brace for 6 weeks or 8 weeks, and then I'm fine and dandy. But if I have, say, a little piece that broke off, that's free floating, that will move, right? And remember that CSF that's in, the spinal cord is in, has the balloon around it, the dura, that can be broken, that can go internally, that can impinge upon the cord, either as I'm laying in bed there with, you know, the normal flow of fluids, or as I'm getting up and now doing PT and walking around. In that case, they would go in probably surgically and fix. Primary, we talked about primary and secondary injuries. Primary is what brought you to them. Can't do anything about that. We really have that huge effect on the secondary injury. So this is what that's talking about. Blunt trauma displacing ligaments, not so much, but bone fragments, and these can cause injury to the cord later on. Those patients go to surgery almost all the time. Hypoperfusion, ischemia, so we talked about not enough blood pressure. You can infarct your spinal cord just like you can have an infarction of the heart or the brain. A bruise is usually blunt trauma, and sometimes a swelling can cause, hopefully transient, but it can be permanent damage depending on how much swelling there was in what area and for how long. Okay. Laceration has to do with, it's exclusively pretty much penetrating trauma. So the knife blade, the gun, bullet, whatever. Secondary, we talked about this a lot. I won't beat this to death for you. Secondary, some of them are unavoidable, but you can minimize further injury through stabilization. And has anyone heard that data out there about them not caring anymore about longboarding people? Yeah, we're not talking about that, okay? Involves complete spinal cord injuries. I've never experienced a spinal cord injury, okay? However, I've cared for many of them over the years in different phases of care as well, okay? Acute, ED, long-term rehab, spinal cord injury centers, things like that. Complete spinal cord injuries are easier for the patients because there's no guessing and it is what it is. Incompletes are hard for them. And I can tell you the same is true for caregiving, definitely, okay? The caregiver, it's easier to care for a complete injury than an incomplete because it's not predictable, it's not routine, and it can change years afterwards on a day-to-day or minute-to-minute basis. Anterior cord syndrome, these are extremely brief. They don't really even need to be pertinent because you're not going to be doing diagnostic criteria within pretty much anything. And most of us walking around as anybody but a neurosurgeon, this includes most physicians as well, really aren't able to distinguish, remember what this particular, you know, set of symptoms goes with that particular diagnosis. Saying that, the one very big, easy to remember one is central cord syndrome. This is your walking quad, okay? So your walking quad, has anybody ever seen one of these? This is very rare. I've never cared for one, ever, okay? It is really, 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 a lot of times not a penetrating or a blunt, sometimes from contusion, you know, so maybe from blunt, or biochemical problems and infarctions, things like that. Depends on where the blood supply was interrupted. But this is greater loss of movement up here, and your lower extremities are okay. Extremely rare. Anybody ever seen one? Okay, anterior cord syndrome. Again, this is just, your symptoms are going to base on what blood supply was interrupted, so it kind of makes sense. Damaging the front of the cord can be a result of those bony fragments that are moving around. This is why they really want to go in and clean those things up. So front of the cord, flexion, this makes sense, right? Posterior injury, extension injuries, back of the cord, that all makes sense, right? Brown sequard, again, I have never seen or talked to anyone who has cared for one of these patients. Have you guys? Brown sequard is stunningly rare. It is an acute hemitransection of the cord, okay? So almost exclusively from a knife. I believe I have a nice picture here. So that could very well could result, I don't know, but result in a hemitransection of the cord, okay? Or a bullet projectile nings it. So you lose the front and the back of half the cord. So everything is way messed up, bad stuff. You lose sensation and touch on one side and movement and proprioception on the other side of the body. Really rare. Like I said, I've never seen one. I've not ever heard of it. Usually you talk to people, oh, that's a good story. Can I have that? Can I use that? I have yet to ever run into it. So keep your eyes peeled. Tell Mark and Blake about it. Perform, when you're assessing, assessment before, assessment after. We've talked to this to death. I won't kill you over with it again. Again, watching airway. So aggressive airway management is really important, okay? You're going to assess over and over and over again. You're not just going to look, but you're going to feel, okay? Feeling for bony crepitus, step-offs, or deformities. And what is the patient having as far as sensation and mobility? Can they feel and can they move? Those are not the same things. Different parts of the cord, different nerves. Watching uppers and lowers to death. Spinal and neurogenic shock, I have a nice table here for you. You will not ever remember this. These are frequently talked about as if they're the same thing, and they're totally different. So, but you have this now if you like it. Neurogenic is a higher injury, okay, and a shorter duration, okay, and it will go away. Versus spinal shock, who knows, okay? So when you've got your neurogenic shock, you're going to pick up your patient. He's going to be hypotensive. He's going to be bradycardia. You won't really notice about the ability to sweat or whatnot. Why? Because he's lost his sympathetic nervous system. No fight or flight, no clamping down, no nothing, right? Okay, so that's the kind of the quicker one. The spinal shock, if you think about spinal shock, has more to do with reflexes, okay? IV opiates, we talked about the one drug, the SoluMedrol. The other thing that's really important to note is that vasoactive medications, this may be the only shock patient that you will ever start a vasopressor on, okay? They talk about atropine here. Much more common than atropine is dopamine. Why do we use dopamine only in spinal shock patients, neurogenic shock patients? We've got a distribution problem. What is dopamine good for? It does everything, and it's cheap, and it's old, and it's pre-mixed too, by the way, right? So that's really nice. Dopamine, what effect does it have on the heart? It's a positive chronotrope, right? So it will speed up, and you will not have as profound bradycardia, okay? Positive chronotrope. And what does it do peripherally? How might it help our blood pressure? Yes, cardiac output is heart rate times stroke volume, so if you increase the heart rate, that might make your blood pressure better. But remember, distributive shock, you've got all the blood there, it's just all pooled down. What do we want from dopamine? The squeeze, the peripheral vasoconstriction, getting the blood back up, giving them blood pressure. So a person in shock, you never give them a drip, right? Never give them epi or norepi or dopamine, except a distributive shock, like your spinal shock, your neurogenic shock patients, okay? Complications, we've killed all this. You know that if they are still, they're going to get DVTs, which will become a PE if they start moving again, so keep them active. Keep them anticoagulated is what you really need to do. Pressure ulcers are a bad thing. This is really kind of silly stuff to be in here because you're not going to be really concerned about giving them their Pepcid in the rig, but give them their gastric prophylactic agent like a Pepcid or a Protonix or something like that. Huge thing, can be a problem in a prolonged transport. Remember, you're laying them flat, or they might be mildly elevated. That Foley may not be draining as good as it should. We talked about that to death. So autonomic dysreflexia, you got to really watch that. Very quickly, talk about stroke. I know I've talked about stroke a lot earlier on. So they divvied this out. If it's a short-term, results are gone. If your symptoms are gone within 24 hours, it's a TIA, a transient ischemic attack. If your symptoms are still there after 24 hours, it's a CVA or a stroke, okay? what they did in your book here is I put the word ischemic next to, because these are all ischemic strokes. I'm not sure why they kind of labeled it like this, but ischemic is not enough blood supply, right? So you can have, there's ischemic strokes and hemorrhagic strokes. Not enough blood or a blood vessel rupturing. Which one's more common? Ischemic, yep. So about 85% are ischemic, maybe even a tidge higher than that, okay? But then you do have the hemorrhagic, which is your aneurysms we talked about. So thrombotic strokes, does this make sense? If a plaque or something kind of breaks off and then either accumulates there and gets stuck, that would be an embolic if it breaks off. But you know, you've got this atherosclerotic plaque and it's harder and harder and harder, and then it just builds outward and then you don't get blood flow. So you've got your embolic when it breaks off and then gets lodged somewhere smaller. Your focal strokes. There's lacunar strokes. I don't know if anybody's ever talked about this. People say, oh, they're just old and demented. That's when you have tons of tiny little strokes and you never know it and they don't find it till autopsy. Not the same thing as Alzheimer's, but those are lacunar strokes. Global ischemic strokes, that's just kind of if you have no blood pressure, you're not going to perfuse your brain, right? So probably by that point you're dead of something else. So, but I'm going to say that. Edema will occur in a few of these, not usually, but our treatments for them can cause cerebral edema. Secondary hemorrhage is called hemorrhagic transformation, and that will happen several days post. Again, you should not see that in transit either from facility to facility or from the field onward, because this is why they do serial exams over and over again to watch. And if they do, it's going to be a very quick, like a sudden bleed. It's almost like DIC, but not as devastating systemically, but it's here. So they can have seizures, that makes sense. So the characteristic sign here is a sudden onset of focal neurologic signs. So that's your FAST, your face, arm, speech, and time, get them there. So do they have a facial droop? Do they have speech problems? And then do they have an arm drift? You know, or you can do your LA or your Cincinnati pre-hospital screen. Symptom onset, not the time you got to them, but the time that they were last seen normal. That's the number one thing, right? Because you've got that golden time window of 3 hours. Watching out because they are at risk just like any other neural problem. They don't protect their airway, they're at risk for aspiration. And upper airway obstruction, all these are from reduced mental status, okay? Oh, it was the LA, yay. Okay, so this is a little bit more complicated. Cincinnati is out there also. Use what your own medical control has you use, okay? TPA, fibrinolytics, may be used. They are great, and the use criteria keeps getting broader and broader and broader every like 5 years. It's wonderful. If you're now 85 years old, it's not an automatic rejecting of a no. I mean, it's on the inclusion and exclusion criteria, but they'll assess it because you can see, like, really, it works great. It works great. Prior to, yeah, we talked about that, exclusion criteria. Intracerebral hemorrhage. So bleeding into, we talked about epidural, subdural, all those. Intracerebral is anywhere else. And I believe I've got a couple of, you know, it can be a result of hypertension, blood vessel-induced rupture. I've got a couple of slides to show you on it. This makes sense. This is repetition. Wow, I didn't realize how long I was talking to you guys. Holy moly. 4:50. I'm so sorry. Take it out on my eval. Symptoms of an ICH can start off as a local problem and then proceed to globally. Remembering that one big one is bad, and a lot of little ones can be just as bad. So those anticoagulated patients or those multiple trauma patients can have these going on, okay? So here is, yeah, I did. Good for me. Bunch of little ones. Can you see all the punctate hemorrhages here? And then a great big gigantic one here, okay? So you are going to have mass effect. You're going to have swelling, which is mass effect, which can cause, this is to the top of the brain, you know what I mean? They're harder to see a little bit lower down. We talked about subarachnoid hemorrhage exhaustively. I won't do that again. An AVM, statistically, when does someone blow their AVM? What age range, I mean? Early 20s. So be very suspicious, okay? Early 20s to mid 20s is when those usually blow. You don't know, they don't know they have them because they're healthy, everything's fine, and then all of a sudden, boom, I've got a huge cerebral hemorrhage. It's not usually from an aneurysm, it's from their AVM blowing. So that's when your arteries and veins are all conglomerated, grown together in really bad ways, like a backwoods family, really bad ways. No offense if anybody's backwoods, I didn't mean it like that. they describe it better. Tangled masses of arterial and venous blood vessels, and there are no intervening capillary beds, okay? It's just oxygenated, deoxygenated in all the wrong spots, and they have weaknesses in the walls, and typically they blow in the early to mid-20s. We talked about this a lot, underline that photophobia because that's hugely present very quickly and prolonged throughout until that blood is completely reabsorbed. This makes sense. If ICP goes up, they might become comatose or die. Holy moly, I've got 5 minutes. Maintain, well, this makes sense. What do you manage it with? You maintain cardiopulmonary function. So you're going to support their blood pressure and whatnot. You're going to try to prevent a rise in ICP. All this kind of makes sense. So cerebral, watching out for cerebral vasospasm. I talked to you guys a lot about this cerebral vasospasm and what we do. We take them down to IR and they fix it. We bulk up their salt. We do triple H therapy. Although that's kind of fallen out of favor, we give them high blood pressures to keep those blood vessels open. So this is where we would induce a MAP of 120 to 140. A MAP of 120 to 140, okay? Overactivity, seizure is overactivity or it could be a result of an electrolyte disturbance or drugs that they're taking or anything, or a plain old head injury. You have somebody fall off the horse, you're going to have a seizure, direct blow to the head, all that kind of business. We might need to give them an anti-epileptic load. They might need to stay on anti-epileptic medications for a period of time, or they might need to stay on them forever. Number one thing you really want to have around is IV benzos. They're having a seizure. The Dilantin is not going to work for a long time. The Ativan will break the seizure activity right away. Okay, you've got to break the activity before you can then, kind of treat and get the airway in and everything else. So maintaining an airway. We don't try to stop them. We don't hold them down. Turn them on their side if you can. Don't put anything in their mouth, ever. Not anything that looks like it was made to go in the mouth, like the stick with the sponge on the end of it. Why do they make things like that? Don't put it in their mouth. Yeah, don't restrain them. Try to get an IV in when they're doing all this. It might not be possible. IM works for certain drugs as well. Check to make sure they're not having a seizure, and that's why. Anticonvulsant load, yes, but you've got to break the activity before you can give them the Dilantin or phosphate load, okay? Transport considerations. Great, we're at like the last 3 slides here. Whew. Major early risks, we talked about this a lot, hypoxia and hypotension. That's it, won't kill it anymore. ABCs, severe closed head injury. Remember, open head injuries, even though they're scarier, and look a lot more attention-wise, they're going to have lower ICPs usually because there's room to grow out, okay? Oh yeah, this is anybody flight in here? I've done some stuff with flight when I was in Army, and I've done a bunch of ride-alongs with Milwaukee Flight for Life, and I have not really seen this, actually, with special stuff for them. They just fly as per norm, but it's possible special protection for the patients. I don't know, I've transported patients with EVDs, only riding along. I'm not a flight nurse, I'm not acting like I am, but that's a possibility. What you really want to watch is altitude, because air pressure changes the higher that you go, so I think that is on here. It is on the next one. There we go. If you need to drop your altitude to equalize kind of pressure for them. Again, no, I do not know of anybody that routinely adjusts cuff size in the ET tube or in the Foley with, again, we're not flying at fixed wing height here, okay? So it's a little, but I don't want to say never. This is per order. I don't like that word must because some docs will want it at 10. Some will want it at 15. But this is a measurement, and again, you can't really tell on this. You have to actually see what device you're actually working with. But your normal setting is 20 centimeters of water is how high you put it in a normal brain. They're not a normal brain, so you get them up in a noisy helicopter, and it might be even worse. If they show changes or any evidence of deceleration, this is another one, deceleration, that's indicating hernias, and get the aircraft down. If it's fixed wing, what are you going to do? But get them down, get them somewhere. Give them mannitol, okay? Is that all right? Did you take away 1 or 2 things, hopefully? Does anything not make sense? Thank you very much for your time. I'm so sorry.